You are listening to the Aizer Health Podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institutions.
Welcome, Dr. Klein, optometrist extraordinaire. Is that fair to say?
Optometrist is good enough.
Okay, well, I'll include the extraordinaire for now.
Thank
you. We appreciate you coming and take time out of your busy schedule to sit down with us today for eye complaints and maybe a general discussion about the philosophy of eye care. Just a little bit of background on you. Where did you do your schooling for optometry?
Pennsylvania College of Optometry.
Pennsylvania. That's not too far, but not too close to New Jersey either.
Right.
Did you live around the area at the time?
Yeah, I had to. It was a 4-year program after a bachelor's degree, so I had to stay there. I like their curriculum approach where they have 6 months extra clinical experience before you go out there and go on your own. So that's why I chose that area.
What was it like living over there? Did you have to move there?
Yeah, I was young and it was hard to move out on your own, but it gave me independence and it gave me good habits and not to rely on anything. So it was a good experience.
Coming out of schooling, what were your first job experiences as an optometrist?
So my first job experience was working with an ophthalmologist, but he really utilized me more for a glorified refractionist. So I would just focus on the glasses, and eventually I was going to build into more than that. Mm-hmm. So that wasn't a great experience. And then I moved on to working in medical centers.
But you were a refractionist extraordinaire.
Thank you. I hope so, but I try to do my part. And then worked in a nursing home that gave me a lot of pathology experience and systemic experience in relation to the eye conditions. So I spent a lot of time working with the elderly population.
Okay, so you went through being a refractionist extraordinaire. You went through a nursing home experience, and then you kind of, I see you now through the halls occasionally, and we have our coffee tabletop or the water cooler conversations, mm-hmm. right? How'd you make your way over to Aizer?
I just saw an advertisement online. I have a Hasidic background, so I was excited to serve the community and relate to them, especially with the demands of learning, needing that their eye should work well. So I was excited for the opportunity to work. And after coming over here and working part-time during COVID, I switched over to full-time. I was working in nursing homes full-time. I was very, very happy to come along fully on board, mm-hmm. Just because of the philosophy of working at the center over here that has a multi-modality approach, collaboration approach, patient-centric approach, which is very cliche, but the center that I work at really, really focuses on that. And just collaborating with all these other providers from different specialties, it just brings that to evidence to that type of life.
Working during COVID, that must have been a very interesting experience as an optometrist. What was the workflow like? You can't remote eye exam people, I don't think. Maybe I'm wrong.
Well, actually, certain aspects, and we have the technology, but for the most part, when you have learning difficulties or binocular issues, you're right, you can't really remote in. But there are certain providers that do that. In the nursing home, it was very hard. I had to, mask up, glove up, gown up, and I had to disinfect equipment, and I had a lot of equipment. Everything was mobile. So, and over here it was also difficult, but we continued seeing patients and followed the proper protocol to keep everyone safe.
Thankfully, the mask over the mouth, not the eyes, so made the exam much easier, right? You don't have to take it off. There's no teeth exam. You weren't the dentist. And we'll get more into your history a little bit later, but you've decided that you solely want to deal with the eyes. The nose is uninteresting to you. The ears are uninteresting. You don't want to see inside someone's mouth. You don't want to hear lungs. You never want to hear what a heart sound is, but you are vastly interested in the eyes. So that has to be sparked by something, right? I don't think that's not happenstance, right? Like, what made you interested in the eyes? Besides for the fact that they're the window to the soul, we all know that. But beyond that, what got you interested in eyes?
Well, really, I was looking to become I had my pre-med requirements, and I was looking at different specialties. So And I found that with optometry, and I have that business aspect of myself as well. So I found with optometry, it's a good mix of having taken care of your health. And the eyes are not just the windows of your soul, but it's also the windows of your health. Because at the time when I was looking into it, it was the only part of the body that you can actually look at, directly view individual blood vessels. And you can monitor diabetes, high blood pressure, cholesterol, and a vast other type of medical systemic issues. So I like that idea where it's clean. You can go in and look to see what's happening in the rest of your body. At the same time, I didn't want to give up the business aspect of selling glasses, selling contacts. And then, in hindsight, I'm happy where I am right now because we work in a medical center where it's many specialties and we're all collaborating and we see the whole entire body. We see not just the focus on the eyes. We see the personality, the everything. And I did away with focusing on selling glasses or fitting contact lenses because I felt that belittled the quality of medical care that optometrists provide. So even though I went into optometry specific with that hybrid approach and running my own business, in the end, I felt most comfortable just focusing on the health aspect of vision.
So I guess two things about that. The first thing is, and this comes up every time actually I've had a guest on so far, where even though we sometimes siphon off specific areas of medicine, now I'm the exception to that because I know nothing about everything, right? Like I know just enough to get by, which kind of makes me have a hand in different aspects of the biology, different pathology, right? Even if someone's focused on, let's say, like, when I was speaking to Dr. Mann, feet, or if even like I'm speaking to you, you're focused on eyes. You're right. Like there's always other aspects, and we'll get into it, I'm sure, more later, where it's the eyes, but the eyes are going to tell you about your hypertension. Yeah, it's your eyes, but your eyes are going to inform you about your diabetes, right? So it's never as siphoned off or as concrete as we kind of make it sound like, oh, all you do is deal with eyes and vision and blurry. No, there's way more to it. So I like that the answer is all of the other things you can see through the eyes and not just strictly based on the eyes themselves. The other thing that I'm wondering though is like, but what was it like? Did you shadow someone? Like I remember when I was in medical school or even when I was pre-med, I thought the eyes were the grossest part of the body. They're squishy. I can't understand how you can see through them. I'm just afraid if there's someone gets something in the eye, what's going to happen? How do you get it out of the eye? Like I find that sometimes it's not the most accessible part of our physiology. Like we can understand our anatomy of our hand a little. I mean, it's a complex hand, don't get me wrong, but you feel more comfortable with it because it's more concrete. The eye is kind of like a different world. So was there something that you had exposure to? You're like, oh, I kind of like this a lot.
Right. Actually, that's a very good point that you brought up because and from my perspective, from a layman's perspective, before I went into optometry school, I saw the eye as the cleanest part of the body. I was looking to become an podiatrist. I'm not going to look at feet, all these infections and ingrown toenails, and then dental. Who wants to look at people's mouths? So everyone has their own choice of what they want to focus on. So before I knew that eyes can actually have some not such pleasant parts of it, especially when they have certain medical problems, I thought the eye was clean, it's simple, and not invasive. So I actually left off with the idea, oh, this is an easy way to go into a field where I can satisfy the patient's direct immediate need, which is giving them clear, comfortable vision, while also being proactive before they recognize that there are underlying issues that can be seen in the eye before they even have symptoms to it. So I had the reverse thought of having the perspective of eyes being clean, simple, pretty, things like that. Everyone has nice looking eyes. I've never met someone with an ugly looking eye. Maybe the parts around it, but the actual eye always looks from an outside perspective nice and clean.
Right. That's an interesting perspective. And I guess, was it also the fact that there was a solvable problem that drew you to it? Some people like to problem solve, right? And specifically with eyes, you can check for someone's prescription, right? So someone goes from blurry vision to clear vision. Is that something that was also, I guess, relatively attractive?
Yeah, big time. It was an immediate direct impact where the person can walk out saying, wow, I see the difference. It's not always the case. There's a lot of underlying personality perspectives of expectations, what people want. But also in going back all the way when I was a student, I was struggling in school, and year by year, teachers would always write on my report card, oh wow, I have a lot of potential. I'm not meeting to that expectation. Such a good boy, but I'm not meeting to that expectation. So I didn't know back then, and only in optometry school did I realize I have a significant number of eye conditions that prevented me to be able to learn and to absorb information visually. So that gave me some.
Do you mind sharing what those are? Like, what
Sure.
were the specific examples?
So I see double. It's intermittent, but as a kid, I didn't know that you're not supposed to see double. I didn't know what to expect it, to set the difference, what is and what isn't. So when I tried to read, I would see words swimming on my page, lose my place, and I wasn't sure which page to follow. And I would literally just see words swimming around. And as a kid, I would play around to diverge my eyes, to see more double, less double, and that took away your attention span. That's one issue. Another issue is I have a big difference between the prescription between my two eyes. So I see not just double because of convergence insufficiency. I see double because one eye, the brain sees things magnified, and the other eye, the brain sees things minified. And if it's too much of a difference, the brain has trouble fusing the image. And then a third problem is I have amblyopia in one eye, where one of my eyes, no matter what you do, can't see 20/20. So those are just three of a few other things that I have with my eyes where, I was just wondering, why am I always struggling? So part of the reason why I also became an optometrist and working with children especially is to see the perspective why they're struggling and get to the bottom of it, because I was in their situation. So I really, the healthcare, I really try to focus on the care first and then bring the health in it. And I think when people see that you're authentic and honest, you care about them, you truly listen to their chief complaint, and then they're willing to listen and to help you find an answer together.
It's so funny that sometimes the best practitioners, you just have to go through something that makes you recognize what it's like to be a patient. Like when we're on this side of healthcare, it's so easy. And I was saying this before, it's so easy to get lost in seeing patients, seeing conditions, right? Like, I'm an osteopathic physician, so they always emphasize in school being holistic. And, once again, I think every physician who practices in a caring, compassionate way is holistic, but they just kept using that word in our training. And it's definitely a buzzword to some extent. And when you're in the thick of things, when you're evaluating patients every day, especially, I'll break the fourth wall down. Like, I'm 20 minutes late for this because I was seeing a patient that I is a complicated case and I really need to give the time of the day and I'm getting here late. But it's arduous. It can be difficult to always hone in on what's going on in the particular patient. But when you, unfortunately, medicine's a two-way street. Unfortunately, we're on that side. Sometimes we're on this side. But when you get a glimpse behind the curtain, when you are on that side, it just informs how to be a clinician so much better, because it just gives you that opportunity to settle back in and be like, wow, like no one wants to be outright rejected, right? Like what you're saying is not valuable or not correct from a medical perspective, right? Like their opinion about themselves is devalued. No one wants that, right? So, but when you have a patient in front of you, you felt like, oh, I got a little dismissed or I got misdiagnosed, or, it just makes you refocus and reframe and be like, listen, the patients are the experts of themselves. I have to take what he's saying, he or she's saying into account, and then recalculate how I'm going to approach this patient. So, and I think it's a running theme. I just think that everyone who has experiences like that, it helps to inform them and make them better clinicians overall. So, separately, I have a relative who had synesthesia, right? So I don't know, does that come up when you see colors around things?
Yeah, that's interesting.
And she always mentioned how I guess growing up, it took a while for them to figure that out, but that was also affecting the reading habits from my understanding, because I guess colors are associated with all these words or pages, and it kind of interfered with it, but it's not a mainstream diagnosis. So I think it probably took some time. I'm not familiar with it. I'm certainly not an expert in it. But certainly, it's not the first thing someone's going to conclude, I guess, when they see someone who's having reading difficulties.
Right. Absolutely. So, many times you can have an induced form of that, certain plastics or certain astigmatism, certain high index of refraction. So you almost have to become an optical specialist as well, where you can have halos of colors around words. It's important. That's another thing I realize, is that what you do in your chair, that's great, but if it doesn't translate where the outcome is the ideal outcome, where there are so many factors. You have to go find the right optical place. You have to make sure that the optician fits you the proper way. You make sure that they cater to the patient to see what kind of lens, anti-reflective coating. So even though optometry right now is focused so much on medical, we can't forget on the outcome, where the patient judges the doctor based on the glasses. And if it doesn't fit right, if it's not comfortable, if they have disorientation, all those factors from the patient's perspective, they're going to judge you. So it's important in my room, no matter how busy I am, to trial frame if there's a significant change, or if I see the patient is very particular, to trial frame, okay, this is what the difference is going to be, just to give you an idea and see the feedback, how the patient is going to respond. And, when you write a prescription, you can't just say, hey, try this medicine in the office before you leave. And with the glasses, you can do that most of the time. So in that sense, it gives me that patient feedback of satisfaction. Okay, I really left not just an idea on paper, but I actually showed it to them, that they're going to be happy with the prescription before they walk out the door.
Awesome. We jumped into the thick of things because I enjoy talking about the philosophy of medicine as much as I like talking about medicine, but I want to rewind for people who are listening or watching and just give them a sense of what optometry really is as a specialty and what it entails. Just because I'm not familiar, I didn't go through that training. But in order to become an optometrist, like how early does one need to even consider the route, and what does the route entail? What is the schooling like? What does the postgraduate schooling look like?
Right. So you get a bachelor's degree, usually in pre-med requirements. It's 99% the same thing as getting into medical school or a dental school. And then optometry school is 4 years of optometry. And then afterwards, you can choose to do a residency to specialize. So even though it's one eye, the eye has so many subcategories of specialties. One eye, but you have many, many different parts of it where you specialize on just that aspect. Just like lawyer, you can't just say you're just a general lawyer. You can be an insurance lawyer. You can be a civil lawyer. You can be a different type of lawyer. So same thing with the eyes. You can choose to specialize or do rotations. So yeah, and during those 4 years, we learn a lot of physics to understand how the concept of the visual system works. We learn a lot of neurology because the retina is, in a sense, part of the brain. And we learn a lot of biochemistry. For what we discussed before with systemic issues to see, and a lot of genetics, because a lot of genetic abnormalities can be picked up in the eye. So we're really, even though it's just one organ, it really summarizes a big portion of your systemic health. And there's a huge behavioral component that I didn't realize until afterwards, where someone like who is very type A personality, stressed, they're more likely to have a condition called central serous choroidal retinopathy, where they have built up a fluid in the retina. So or the pressure can be high, just like blood pressure when you measure it. So you can really get a feel of the personality, how behavior and philosophy drives the outcome of your health as well. So everything is truly interconnected. Mm-hmm. And yeah.
Now, I feel like in optometry, there are a million letters that are thrown around and we can't figure it out, right? There's PD, there's all these other, what's your classic, if someone is walking into an optometry clinic right now and the optometrist is talking to them and maybe they're not you and they're not giving that kind of attention to detail, breakdown and understanding for the patient. What are all these letters, words? What do they mean? Because I can't figure it out. I'm sure if I can't figure it out, there's a lot of people out there like me who don't know what's going on. If you could just break it down for us.
Yeah. So a lot of these are borrowed words from Latin. I have to go back to actually learn to remind myself of the actual words. For instance, OD represents the right eye, and OS represents the left eye.
I can't memorize that for the life of me. OD is the right eye. OS is
left. Yeah.
And then what's both?
OU.
OU.
Yeah.
Can't figure that out. Will never stick. I haven't figured out a mnemonic to make it stick, but okay. So those are and what about the other nomenclature that generally is thrown around, like pupillary diameter? What does that mean?
Yeah, pupillary distance, the distance between the two eyes, and so when you measure a pair of glasses and you put it, that's where the optician comes in usually. And I can write the best prescription, but if the optician doesn't truly measure where you're looking through the glass. And usually you have to look through the center of the optical zone. And that's where physics comes into play, because if you don't properly measure, depending on your amount of astigmatism or how high your prescription is, you can get induced prism. And prism can sometimes be used in your favor. So I mentioned before the diplopia, double vision. You can actually write certain prescriptions to help with the diplopia so it just doesn't occur as much. Now, it usually works best with vertical diplopia when people's eyes are not vertically aligned. So
What
you
is
can,
it, like physically on someone's face?
yeah. Or so the eyes are, it's not just the eyes, there's 12 extraocular muscles total. It's like gyroscopes. They have to constantly work together and team together to ensure.
Those are the muscles surrounding the eyeballs that pull them in every which direction.
Right, exactly. So they, in a sense, dance together so they can be in harmony, so the brain doesn't get disoriented or confused. Okay, which way am I going? And that's, simply as reading a paragraph entails so much micro movements and saccades, and there's so much energy put into just this very fine motor system. So some people don't have a good system, so they either need vision therapy or prism to help them align their eyes. So you have to really make sure that you measure where the patient looks through the eyes, and the distance PD is different than the near PD, because when you look at near, you converge your eyes, so it tends to be a narrower, a smaller PD, and that's just the one plane.
So what you're saying is when you convert, meaning converge, bring your eyes together. So that's a closer distance because they're kind of facing each other at that point.
Right.
Okay. And how does that factor into glasses and?
Right. So because when you look at infinity, your eyes are a different PD. Let's say the average PD for males is roughly.
What's infinity?
Infinity is like anything beyond 20 feet. Uh-huh. So that brings up to the topic: why do we test the patient at a certain distance? Because based on the math, at 20 feet away, it's almost as if the vision is at infinity, looking beyond the horizon. Mm-hmm. So that's where the eyes are most diverged. They have to diverge their eyes so they can have proper depth perception. And then when you look at a computer, it's another distance, a narrower distance. When you look at reading material, it's even narrower. Looking at a GPS. So when you get, let's say, a multifocal glasses, some people need bifocals without a line, called a progressive lens. They need to be really measured and a great detailed. Make sure it's not just perfectly aligned, so that where their eyes are focusing in the right location. For instance, the prescription at distance could be a different prescription at near. So you're looking at a pair of glasses and you're seeing well, but you're not only looking at one fixed distance. So your glasses at the demands of what we use at learning at near, looking at a computer, looking at a GPS, they all have different areas of the glasses that it has to have the right prescription. So people just try it on the glasses and they're happy, but there's a lot of engineering, a lot of thought, a lot of measurements done to ensure that the glasses work best for the dynamics and complexity of our world.
Mm-hmm. So what you're saying is it's not a simple prescription. There's various aspects of the lens that have to be correct for a specific sight line, so to speak. I'm not sure I'm being technically correct here, but I'm just trying to make sure I can explain it as best I can.
So for a young, healthy child, usually the prescription is the same, because another part of the eye is that they have the ability to accommodate. It's like a camera that zooms in and zooms out. So if they have the proper accommodation, they just need one prescription that makes them see properly at distance, and then the eyes can perfectly align as well. But if you have an abnormal accommodative issue, or like I mentioned before, if you have a binocular issue where you see double, or at a certain age, past 40, people start losing their focusing. At near, they need a bifocal, or someone who has huge needs on their eyes at near, such as learning heavily students, even though they're young and healthy and they can focus and accommodate, we give them a bifocal as well, because it's based on also their quality of life and the demands that they expect from their eyes. Mm-hmm. So, having a SOFR, I write specific SOFR glasses, because usually they're 6 to 8 inches away from writing. So they need to make sure
very zoned into the writing.
Exactly. They're specific computer glasses. There are all various types of specials, just like shoes. You got your runner shoes or your hiking shoes.
Mm-hmm. Any other terms that someone should know when they walk into their friendly neighborhood optometrist office that they might find confusing?
People confuse cataracts. They confuse floaters. Sometimes they have an idea. Sometimes they mix them up. Usually when I ask for a family history of glaucoma, they usually say yes. But when I follow up, they say, oh, it's cataracts. So just certain terms. Just also what's really important, get a family history of what eye issues, eye conditions your family has, your parents, your siblings, your aunt, your uncle, because a big portion of what your outcome with your eyes have to do with genetics. So just so we can monitor those things.
So essentially what you're telling the average person is, if there's a family history of eye problems, try and get it straight so that if you have, your annual visit or you're seeing your optometrist, you can give them an accurate portrayal of your medical history, because that's more indicative. Family history is indicative of potentially what the patient could be facing now or in the future.
Right.
Okay. Is there I'm going to admit something right now. I haven't been to the eye doctor since last time I saw you, which has been some time. So I know there's a bunch of machinery, there's a bunch of equipment in there. You kind of get passed between one test and another test, and as a purveyor, as a visitor, you have no familiarity with any of this equipment. Is it possible you can take us through like all those machines and what they're called and what you're measuring in each machine? The best that you could explain it to someone who doesn't understand anything, such as myself, but to give someone a good overview of what to expect when you go into your optometrist's office.
Yeah, absolutely. There are a lot of machines, and we live a day and age where there's so much medical technology, and it can be overwhelming. For sure. So, and we have a lot of equipment, high quality, high technology equipment. Just today, I had a retinal specialist call me up asking me why I refer the patient. They don't see anything. And thankfully, with the technology and the staff, that the qualified, highly trained technicians and providers that we have, we were able to discern an issue. And with the support of the technology, we were able to provide the information to the retinal specialist, where otherwise we would have missed it and he would have missed it. So technology plays a big role. So the first and foremost, despite having a lot of technology, we greet a patient and we take a good quality history, because there's no point of having a bunch of devices and just using it randomly. You have to be targeted. You have to know what you have to come up with a hypothesis, what the issue is. And you use the technology to reaffirm your diagnosis, to verify it. So we start with the patient having their acuity tested after taking good detailed history at distance, at near. We verify the prescription they came in, if they have a prescription. We verify their drug allergies.
The acuity testing, is that the classic chart that everyone thinks of?
Yes. Yeah. And that's just a quick screening. The doctor verifies the acuities as well, because that is really the main part where the patient judges if the outcome, if the vision is good or not. So I can be the best doctor in the world and finding the most interesting things in the back of the eye, but not always does that translate to patient having an issue with their vision. People can have perfect vision, and there's something that's time pending, that's very urgent, that needs to be addressed in the back, and they wouldn't know it. Mm-hmm. By the time they know it, the condition went further than it should have. So we do that, and we measure the pressures in the eye, just like measuring the blood pressure. It's eye pressure is a silent killer. Not always do we know that the blood pressure is high, so you have to measure it. And we have three different modalities of methods. Three different methods to check the eye pressure, just on that, to verify that it's accurate. And we also, during this time process, we also make sure the patient is not nervous. So we have great providers and technicians that emphasizes to put in a calm state of mind, because when someone is stressed, the pressure is going to be high, and then we're going to do
the pressure in the eye can be high, just from physiologic being nervous.
Yeah.
Oh wow.
Not only that, I once had a patient who I mentioned, I'm going to measure the pressure in your eye, and I told him what's going to happen, and he fainted.
You didn't do anything?
Didn't touch him.
Wow.
Just the thought of it, the power of mind, vasovagal,
Wow, that's impressive. So you start off with a strong history. You try and focus in on what the issue is. You follow that up with an acuity test. which you do that yourself or technicians?
We have amazing technicians, and they do a lot of the pre-testing. So acuity test, distance and at near, and we have an imaging device where we have this amazing non-invasive technology that can get a view of the back of the eye, the retina, which tells us so much about our body. It gets most of the retina, and within that device, if the technicians see something abnormal, and they're highly trained diagnosticians themselves, they do a OCT scan to ensure that.
What's an OCT?
Optical coherence tomography, where it's just, so when you look at the back of the eye, the retina, it's not one tissue. It's like a 12-layer cake, and it's just tightly bound, one layer on top of another, that has to be working perfectly together. And depending on where you see a lesion, you can diagnose different things. You can diagnose diabetes, hypertension, strokes, glaucoma. There's now research about looking into pre-testing ahead of time for Parkinson's and Alzheimer's, other autoimmune disease. The list goes on and on. So based on what they see, they pull up different technology devices to scan which layer of the issue is. So by the time the patient walks into the doctor's room, we have a really good idea of what's going on before even seeing the patient.
So you collect the history. Acuity test, pressures, and you said 3 different ways. What were the 3 ways to do it?
Well, there's a puff air test, which it sounds not a big deal, but patients have a natural reflex to protect their eyes naturally. So that's a little bit more uncomfortable. We have an eye care device where it's a small little probe where it has a very small surface area where it quickly goes and taps the cornea. So it does touch the cornea, but it's so quick and fast, and the rebound is measured to see what the pressure is, but it could also be not so accurate. So technology is very important to get the right technology that's pragmatic and reliable. And we have another one where we numb the eye up, and we actually use a different device. It's called a Goldman tonometry, where it actually touches more surface area of the cornea. And I believe you have the TonoPen, right?
I share your devices. Yeah, we use yours when we're in a pinch. Because I'm very indecisive and haven't figured out which equipment I exactly want. Because I see the advantages of each one, and different physicians have different familiarity. But I wasn't sure what all 3 of the methods were. So you'll use any of those 3 methods for the intraocular pressure, and that's just the pressure of the eye. And maybe we'll get more into that later. And then you said you'll do the retina scan, and then sometimes the OTC, the
OCT, yeah,
the OCT,
so depending on. So, for instance, certain people who are diabetic, automatically by default, they get a more detailed scan to make sure that all layers of the retina are healthy. People who are highly myopic, they automatically get
What's highly myopic mean?
People who are very, very nearsighted, have very high numbers.
I can't keep this straight in my head. Nearsighted means they can't see near.
Yeah, it's very confusing. Nearsighted means that they're naturally able to see at near. And farsighted,
naturally able to see near.
Yeah, without any correction.
Okay.
And the question is, what is near, right?
This is a philosophical debate now. What is near?
Right, exactly. Yeah. So the higher the nearsightedness, the more they have to bring the material closer to them to see things.
So the higher the nearsightedness, the worse the vision, and the more near the object has to be for them to be able to visualize it.
To see in proper focus. Okay. Yeah.
Okay. So, and what's the opposite of that? The farsighted.
Farsighted. Farsighted means you see well at distance, but you're straining, you're borrowing your focusing muscle. As I mentioned, the accommodation, you're borrowing the focusing muscle to use it for distance, but then you have very little left for near. However, that's also not so clear, because if someone is highly farsighted, they don't see well at near or far. It's just they're seeing more blurry at near.
They can't see anything.
Yeah, exactly.
Okay, gotcha.
Yeah.
Right,
so and there's these ideas about people's personalities shaped based on their prescription, and we, as people, we love patterns, we love logic, and going back to what you were talking about before, about patients having their own ideas of what did you mention before about patients' approach to things with supplements or.
I mean, I think that patients in general, depending on what you're referring to, I think they are not familiar enough with what we're doing. So they kind of walk in with a sense of, with their own, I don't want to say trepidation, but you kind of, especially in your field, you're throwing them through a gamut of multiplicity of tests. And I guess you have a sense when they're doing the, 1, 2, or 3, 1 or 2, 2 or 3, that, they're looking at the acuity, but then, there's someone flashing a light in your eye, and there's someone
Right.
bouncing a little bit of a ball off of the top of your eye, and you don't know what the deal is with that. So I think there's more of sometimes between the nomenclature, the wording, and just the process, there's a lot of confusion. They come out wearing glasses in your particular case, but I mean, you can apply this to every form of medicine where someone comes in, the nomenclature, the wording is confusing. There's a whole process and a litany of tests that don't seem to make any sense. And you kind of come out the other side with some objective outcome or result. And the patient's sitting there like, I don't really know how we got here. So I don't know if that's what you're referring to, but that's the thing that, I'm hopeful that there's a way to correct, at least through patient education,
Right. Yeah. My technicians really do a good job communicating what tests they're doing and why, but also we don't want to give too much detail because their guard goes up and then they start impacting the reliability of the test.
Right. Well, I find that's funny that you bring that up because like the tetracaine, right? So from an urgent care perspective, we'll see, and we'll get more into a little bit of pathology and different disease processes later, because I think that's really valuable for you to help discuss with us. But when I see someone who has they got a scratch on the outside of their eye for, corneal abrasions, the official term, and it can be very painful, right? When I see them in an acute care setting, right? So the first thing I give them is a medication called tetracaine, which you're very familiar with. The problem that I run into, and this is where I'm circling back to, is that from my understanding, it burns a little bit when you put it in. I think I've tried it once on myself. But when you tell someone when you're about to put an eye drop in their eye, when they're in pain, that the eye drop's going to burn a little bit, but then they're going to be pain-free. Generally speaking, I think the only thing they're hearing at that point is, hey, I'm going to put an eye drop in your eye and it's going to burn. So how much information do you give them before you actually perform the test? And that's what you're trying to say right now is, and if you give me, I guess, a couple examples of how it impacts the actual reliability of the test, because that's, you're trying to negotiate informing your patient, but you also need a reliable test.
Right. Yeah. So tetracaine is a good example. So there's another one called proparacaine, and it stings a little bit less. So it's also probably
every patient that I've seen in the past who I've put tetracaine into the eye right now is kind of looking or just shaking their fist like, why didn't he have that other medication?
Right, but then they want to take the bottle home.
Right.
So when I tell them, especially for the children, if I have to put drops, dilation drops, for instance, dilation drops sting also. In fact, many times people put in a proparacaine or tetracaine beforehand and then put the dilation drops because it stings that bad. And also because they have to numb the eye to measure pressure. But now we have better non-invasive abilities to do better screening for eye pressure. However, when it comes to real concerns, we have to go back to the Goldman, which is actually touching the eye, so we have to numb the eye as well. So for kids, for instance, I tell them it's just a drop that's going to tickle a little bit. It might sting, and if it does, just blink, blink, blink 10 times fast. And they're so focused on the actual task of blinking that they don't even think about the stinging. So that's
You've given them something to focus on, which is not the stinging that's
right.
about to happen.
Right. And then I help them along if they're freezing in place. So I by moving the lids up and down and tell them to count how many blinks they did, things like that to distract them and to be part of the team to actually help us get the information.
When do you have to dilate someone's eye? It's not every eye doctor appointment that the eye gets dilated, but it's some. How do you make that decision?
Yeah, that's a big debate within the optometry and ophthalmology world. Technology has really improved our sensitivity of picking things up without having the need to dilate. We still dilate.
So to dilate the eye is to make the pupil or the black part in the middle,
Right.
I guess, and we'll get to terminology. Maybe I should have done it now. I think this is our opportunity. This is our opportunity. We're going to do a drawing lesson. For those listening, I apologize. We're going to do our best to describe what we're doing visually. That's going to help people understand what we're talking about from an educational and maybe an entertainment perspective as well. You'll do the honors on this? You know the eye way better. I'll help where help is needed. But I guess if we could go through the parts of the front of the eye so that people can kind of get a sense of what a dilated eye looks like in that exam.
All right, let's see. It's been a while since I drew.
You didn't know there was going to be drawing lessons.
No, I didn't.
This is the surprise test. If you can't draw a perfect circle, you failed. The question really is that how do you decide when you dilate someone's eyes? Because sometimes I don't know if I've had my eye dilated, but from everything I've heard and seen, it seems very uncomfortable. The middle black part of the eye gets super wide.
Right.
Lights get super annoying and difficult to look at.
Right.
So if you don't mind sharing with me your demonstration on the eyeball. And
yeah. So ahead of time, I apologize for my horrible drawing. Okay, so this is the
does not look like a circle, just to be clear.
Okay, so here's the cornea. You don't usually see the cornea because it's clear, but it actually acts as a lens.
Yeah. And this is, just for clarification, this is looking at someone's eye.
The front, yeah.
Right. So that curved part's the front. Right. And if you can imagine, the rest is inside the person's body, right?
So yeah, so here's the cornea. Usually you can't see the cornea.
Right. So this is once again looking at it like it's the front part is what you kind of see, and then the rest is in someone's body. So if you're slicing someone, not that you should do this at home, slicing someone in half down the nose, this would be like what you'd see on the side. Yeah.
So just a quick anatomy lesson. This is the cornea. This area is the pupil. It's black. It's not really black. It's just dark in there. And if you shine a light, it gets illuminated. And behind that is a lens. And when you get older, you get a cataract. It gets opacified. And this is the back of the eye, the retina. It's a very simple drawing, and that's the nerve that goes to the brain. So corneas can also get cloudy. So cornea is like a layered onion. It has multiple layers in it. So when you have someone has dry eyes, it could be a corneal problem. But the cornea in the eye is also within the eye, in the eyelids. And the eyelids secrete oil. It's not just to close and open your eyes. It secretes oil because when you mix water and oil, the oil rises. So the body makes its own lipid, oil, fat, so the tears that is created doesn't evaporate so quickly. Mm-hmm. So that's just one section. And there's a dry eye specialist just for dry eyes because there's like 4 or 5 different categories of dry eyes. So then we go to the pupil, right? So when during the daytime, the pupil's smaller, and during the nighttime, to get more light in the eye, the pupils get larger.
Yeah. And the pupil, it's not saying that, meaning people see the colored part of the eye, that's the iris, right?
Right.
And then the lens is right there behind the eye. And the pupil it's kind of that part that moves, so to speak. So sometimes how you see more of that black area and less of that black area, that's the pupil getting bigger and getting smaller.
Right.
Reacting.
And the pupil is very interesting because when you accommodate, when you read, your pupils constrict.
What's accommodate mean?
Accommodated.
We write it all the time in our medical charts, but just for the audience, what does that mean when it accommodates?
Our visual system is very dynamic. You can't just have a fixed clarity at distance. You look at far, near, and every time you look at far, near, you have to automatically focus, zoom in, zoom out.
It's a lens, a camera lens.
Right,
okay.
Exactly. So, and when you look at near, your pupils get smaller, but also a few more things happen. The lens gets fatter. Because when it gets fatter, the lens actually has little zonules, which is hard to draw over here. And when you focus at near, the zonules loosen up, so the lens becomes fatter, so you can focus naturally more at near.
So it gets thicker from front to back. It gets thicker,
right? And
that helps with your focusing. Okay,
right. So, and that's just with one eye. Now with both eyes, you converge as well. Yeah. And then when you read, you have to go from one word to another word. So then those are the 12 extraocular muscles that work well together. Mm-hmm. And just on the pupil, to dilate, that is involving the sympathetic nervous system, and to constrict, that involves the parasympathetic nervous system.
So without getting too far into the weeds, when as an optometrist do you need to make this eye look bigger and dilate it?
So in order to be able to look at the health of the back of the eye, we need to open up that pupil size to get a better view. Mm-hmm. And if the pupils are very small, and with age, your pupils tend to get smaller. And with age, you tend to get cloudiness in the lens that obstructs our view.
Right, and that's the cataract that
exactly.
you're talking about. Okay.
So anyone that has an issue in the back of the eye, or just a first-time visit, just to make sure proactively that there's no ocular issues in the back, they should have their eyes dilated.
So it's like opening a window to look into a house, essentially. You dilate the eye, you open the window, right. You get a look around the back of the house, you make sure all that looks okay, and that's essentially... Now, when someone gets their eye dilated, how long is it dilated for on average?
So just with talking about tetracaine, proparacaine, same thing with dilation drops. There are multiple types of dilation drops. So if someone is a child I'm suspicious that they have latent farsightedness, that they're hiding more plus. The eye always wants to see well naturally, so that lens gets fatter and always wants to see well. So they could potentially be hiding a higher number of plus of farsightedness, and because they're not relaxing their focusing muscle because they want to see well. So sometimes we don't just dilate. Sometimes we need to cycloplegia the eye, where we paralyze their zonial muscles so they cannot squint, they cannot focus, they cannot accommodate, to find out the true prescription. So dilation is not always just to look in the back of the eye. Another example, I had a patient who had uveitis, inflammation of the iris, because behind the iris, the immune system comes in, and sometimes...
The iris, that's the color part, right?
Right.
Sometimes brown,
Right.
blue, purple,
Right.
rarely purple. Yeah.
Yeah, different
Shades.
Yeah, definitely different shades.
Purple with colored contacts. Right.
There you go.
There you go. Okay.
And so we dilate also when someone has inflammation in their eye, sometimes from Crohn's, sometimes from rheumatoid arthritis, or other type of autoimmune diseases, or just idiopathic, sometimes from a prior viral infection or other factors. So we also dilate their eye because we don't want more of that immune cells to come into the eye and cause inflammation. So we kind of freeze that muscle to not allow more of the immune response to come in while we calm that inflammation with steroids. So you use dilation for various reasons.
Couple reasons. Okay.
Yeah. But the main reason, like you said, is to get a better view in the retina. And with today's technology, we don't have to do it as much.
Okay. So, we're going to get more into the weeds shortly about different eye pathologies, different eye illnesses, ways to look at the eye, things that people should be aware of. But just to get more into kind of your experiences as an optometrist, what was something you didn't think about before becoming an optometrist that after years of practicing has become so fundamental for how you treat patients? Something that you never even thought about until you started treating patient after patient, and then it's become part of your practice.
So I used to just focus, like you mentioned before, in a scientific, objective way, just to resolve their problem, and that will be the answer that serves itself without having to do anything else. But with so much experience now, I realize a big driving force of patient satisfaction and outcome is knowing the person's personality, really getting a gauge of who they are as a person, what their lifestyle is, what their expectations are, and their personality. Really, you can have the same person with the same diagnosis, and one will be super happy and one will not be super happy based on their personality and their expectations. So I have to reset expectations sometimes, or sometimes I don't get fixated on giving them the best vision. If it's not a clinical issue, or it's not going to impact their quality of life in a very negative way, then I accommodate and I give them the prescription that they perceive to be the best one for them.
It's a little bit of a negotiation in some, when I practice, and obviously we don't have the same form of practice, being urgent care, emergency medicine, but something that I've noticed is that, similar to what you said, when you come out of medical schooling or scientific schooling, right, the approach is generally, even if it's holistic, it's so science, right? One of the most fundamental pillars of evidence-based medicine, and I've learned this from Ken Milne, just to throw out a name. He's very in the academic emergency medicine sphere, VELT, if you will, but it's taking into account what the evidence says, what are the studies, the clinical trials, but it's taking into account your experience. That's important as well. And then the third thing is the patient values, right? So if you're trying to only impart your experience and what you've learned from a clinical trial on someone who you really don't understand what value they have, what's important to them, that's generally when there's a mismatch in medicine and you don't actually leave someone feeling fulfilled by the clinical evaluation. Just for a more concrete example, I work with the PAs and residents in the hospital, and I always try and impart this piece of advice. The medical record is very important. It puts a lot of importance on chief complaint, right? What is the patient's chief complaint here? Are they here for chest pain or shortness of breath or toe pain? What is it, right? Ask them about their chief concern, right? What are you concerned about the most? Because generally that's not the exact same thing as a chief complaint. A chief complaint is chest pain. A chief concern is, God forbid, someone's father passed away early from a heart attack. Am I having a heart attack like my father? God forbid, right? Like that's That's a very different question. So you might approach it the same way. You might get the same lab testing, but if you don't specifically go to that patient and say, hey, listen, we did the heart marker twice. It was negative. It was normal. The EKG looked great. Your lab work looked great. This is not a heart attack right now. Definitely recommend you see a cardiologist, but it's safe for you to follow up with your cardiologist and your primary doctor outpatient the next couple of days. That's a relief. If you go in and say all the tests were negative or normal, you're good to go home. That's not a sense of relief. So knowing what the patient's there for, negotiating what the patient values with what your understanding of medicine and what the science has taught you is to me, that's the trifecta. That's the tripod of taking care of patients in the best possible way. So yeah, just like you said, you have to kind of sometimes also negotiate your initial plan because, sometimes you feel X, but a patient feels Y, and you kind of have to meet somewhere between
Right.
X times Y. I don't know where
Right.
that is,
Yeah. I'd give them that driving seat. And I was always focused on giving the best answer, but it's not always the best answer from my perspective. It's what works for them. Yeah.
Right. We were speaking about this, and I've said this before, I don't know who I'm quoting, but I'm definitely quoting someone here. So I apologize for the misquote or the malquote or the non-quote, but no one cares how much you know until they know how much you care, right? Part of what the recipe for success in a clinical encounter is if you don't look engaged, attuned to what's going on with the patient or what their concerns are, you could be the best doctor in the world. You can be from the most prestigious institutions. I just don't think people are going to connect or they're going to listen to what the recommendations are at the end of the day. What was the thing that maybe tickled you, like surprised you when you became an optometrist? Like maybe a proverbial question that comes up that I don't want to say it's silly, but it's kind of that question that people keep asking, like, wow, I didn't realize this was going to be such a significant part of my day job. I think they're the obvious bread and butters of optometric medicine, if that's a phrase or a term. But what is the thing that kind of surprised you that you encounter daily or weekly?
I'll have to think some more about that.
What's the funniest thing you've had to pull out of someone's eye?
I recently pulled out an eyelash from the inside out.
What does that mean?
Well, you know how the eyelashes grows from the eyelids.
Sure.
And it was the strangest thing. It's nothing grotesque, but the eyelash was embedded deep inside the eyelid, and it wasn't visible from but something was stabbing, and you can see the markings of the scratching of the cornea, and I couldn't figure it out, but it was the base of the eyelash, and I had to pull it from the back of the eyelid. And it's not really possible because the anatomy doesn't allow the eyelashes to go reverse in that way. I mean, there's trichitis where there's scar tissue on the eyelids that you have to pull out because it doesn't turn around and stab you. But this is literally pulling the eyelashes from the inside out. It was very, very weird.
Two things that I love about that. The first thing is your grasp of all these crazy words that I can't even pronounce, which is just amazing. Trichitis?
Trichitis.
Wasn't going to get that anyways. That's fine. But you rattle them off like it's like no big deal, which I love that, because even the medical words I've been saying for however many years now, I can barely get right when I'm talking to patients. So you just have such a fluid connection with the words I use. And
maybe it's trichitis.
Whatever you said, it sounded perfect. But the other funny admission that I'm gonna make right now is that there was a time a couple months ago where I was walking around every day with a painful eye, and I wasn't going to get checked out. I wasn't going to a doctor. I didn't see anything. And this went on for probably weeks. And I would tell my wife, like, I would say, I don't know, something, it's painful. And she just, why don't you see a doctor? I'm like, I don't need to see a doctor. I'm not going to a doctor because, we're the worst patients, of course. And one day I just got up and I looked into a mirror and I was blinking and I was just like, what is that? And I noticed that I had an eyelid that was just floating around, an eyelash that was just floating around my cornea, the outside of my eye. And it had probably been there for at least a week or something, or maybe two, because I was having this ongoing pain. I was worried about glaucoma and all these awful diagnoses, and I refused to see anyone. And I took a cotton Q-tip and just got it off, and the pain went away entirely. And, it kind of reminds me of the parable of like, was it the lion and the mouse, right? And the lion is the biggest animal, right? And it's roar and it's scary and it's the king of the jungle, so to speak. And it had like a thorn at the bottom of its foot, and it needed this mouse to pull out the thorn. I hope I'm getting this right and not botching it. It's an elephant. Thank you. I appreciate that. Well, listen, the fiercest animal we all know is the elephant. It's not the lion, right? So, and it needed the mouse to pull this little thorn out from underneath because it just couldn't get to it. And sometimes the solution's that simple, but you just,
Right.
doctor, heal thyself. And it's, I couldn't heal myself,
Right,
but
right.
I eventually got to it, and I probably should have come to you earlier, but that's a story for another time.
It turned out okay.
But,
Unfortunately, with the vision, many things that hurt a lot need to be addressed, but they don't really drive the ultimate medical emergencies and concerns. It's usually the things you don't feel. They're the deadly ones. So specific with vision, there are many conditions that people walk around every day.
Yeah.
They see fine, they feel fine, and there's something happening and they have no clue.
So we're going to get to the eye conditions. I want to pull that up actually, not too long, but just quickly, a couple of things as far as, what worries you? Well, before I get to that question, just for some clarification, when do people have to see an optometrist? When should they see an ophthalmologist?
Yeah. So
what's the difference?
So the basic idea between an ophthalmologist and optometrist is that ophthalmologists, they went to medical school and then they went to residency to specialize in ophthalmology. And within ophthalmology, they can specialize in general ophthalmology, or they can specialize in the retina, cornea,
the back of the eye,
right,
cornea in the front of the eye.
Cataract surgery. They can specialize,
and that's on the lens.
Right, strabismus surgery. When you have a lazy eye, they have to correct their neuro-ophthalmology. There's subcategories within ophthalmology as well. So usually the ophthalmologist, you won't find an ophthalmologist this day and age where they don't perform surgery. Almost every ophthalmologist perform surgery. So the main differentiator is that they do surgery. But even that, based on certain states, some optometrists can do minor surgeries, certain lasers, certain lesions on the eyelid. So that can be treated. We both can treat glaucoma. We can both manage macular degeneration. We cannot treat macular degeneration when it involves surgery. We can.
The macula is
at the back of the eye that allows you to see clear vision.
By the retina,
by the retina, exactly.
Okay.
So the overlap has become greater because optometrists are trained more and more and proficient more and educated more.
I'm sure this is sometimes the point of a contingency between different organizations and what people can do. That's
right.
always.
But for the most part, collaboration is great. Ophthalmologists, they just want to see their main specialties, and anything extra, they want to work with optometrists. They're almost relying on the optometrist to see the things where 20 years ago ophthalmologists would see routinely. They're done with that. They're moving on to a higher order, more complex things. So there's that symbiotic relationship.
Symbiotic.
Yeah.
Now, as far as the next 10 years, what makes you excited for the field of optometry? What makes you scared for the field of optometry?
So we're at a stage where we're in massive information overload. When I have a glaucoma patient, which is talking about pressure in the eye, I have to use a visual field. I have to use an OCT. Now they have OCTA, which measures the vessel density. I have to measure the pressure. I have to measure the corneal thickness. And we have to measure all this information over time. And there's so much data points. So I'm so happy that AI is coming into play. I can't imagine medical devices not having integrated AI specific to the medical device specialty, because it's so imperative. I can spend 15, 20 minutes sometimes charting and interpreting the data of one patient. And that's what patients don't realize, because when they walk out the door, they think that the exam process is over. I have to do a lot of charting and take all that data and process it and come up with one final outcome. Do we treat it? Do we not treat it? What the follow-up care is and how frequent the testing has to be done. So I'm so happy with technology having AI integration, and that seems to be going in the direction that I'm very excited about.
And what about your concerns? What are you concerned about the next 10, 20 years?
So AI has its flaws. And one of the concerns is that if technology is replacing employment, replacing certain procedures, and they're making it easier, so you can have a general doctor doing things that they never envisioned doing, and that's good. Where the layout and the access to care is easier, but that's also not good because when they are outside their field, they're outside of their scope of practice. Maybe they became a little bit too overconfident, and then they want to keep it in house and not knowing when to refer at the right time. But that's kind of the case right now within all our fields. So it's important to learn your skills, but it's also important learn to know when, it's okay to refer out and to have that collaboration, not to lose that.
Mm-hmm. I mean, that's the complexity of medicine, right? Like as I said, when we started, we all have a wheelhouse that we're in, and trying to identify when you're at a transition point in the wheelhouse and it's time to, tag someone in, so to speak, and to, bring other partners into this patient's care in order to collaborate and take care of them in the most effective fashion. Certainly in my line of work, that's always the question. And you get my texts sometimes when, there's a patient I'm concerned about. It's not every patient I see with an eye complaint, but it's the ones where it's like, it's just a little bit more complex. I'm a little bit more worried because of, maybe specific social factors with the patient, but having to tread on that fine line is sometimes, it's a judgment call, right? It's right. You want to do what's best for the patient, but you also have to make sure you have an effective system in place, and you're not overworking your optometrist colleagues who's at home enjoying his good life while you're working at 11 o'clock at night. So
yeah, I love those 10 o'clock, 11 o'clock texts.
Sure, yeah. That's why I send them to you, because
great visuals, freaking me out. Okay, send them in the next day.
Yeah, exactly. So, exactly.
Yeah, it sounds like urgent care keeps you quite busy.
Yeah.
From head to toe.
Yeah, from head to toe. That's. I knew I couldn't focus, so I did all the things that I could do.
Right.
But the best part of what I do is I get to. I think about this all the time. So many other specialties, aspects, and forms of practicing medicine are, like we said, are siphoned off. You only do one specific thing, and the corollary of that is sometimes you don't have a lot of encounters with other fields and professions. I talk to everyone. Just by the nature of my work, I'm talking to the pediatrician, I'm talking to the internist, I'm talking to the optometrist, I'm talking to the ophthalmologist, I'm talking to the cardiologist. I get to talk to everyone because I have a little bit of a concern about all the different aspects of the patient's anatomy. So for me, I get to formulate all these different relationships, which are
and it makes you more proficient as a urgent care doctor.
Yeah. I definitely appreciate that form of how I practice.
I was going to bring up one of the concerns that I have is because everyone's Dr. Google these days.
Oh, sure.
And the problem with the age of information overload, it's also an age of irrelevant, accurate data. And there are specialties and things out there that supplements that promote getting rid of floaters, for instance, where there's absolutely no scientific basis on that. So there, unfortunately, you would think that the snake oil salesman is gone, but it's just reinvented itself in a different way. Mm-hmm. So unfortunately, with society, just like technology elevates good healthcare, but also elevates other things that are not accurate.
Yeah, to that point, and I'm not going to take credit for this because I certainly listen to a lot of smarter people who have mentioned something like this before, but there was a perfect time where maybe we had just the correct amount of information influx, where we'd receive just exactly what you'd need to know, and everything got collated nice for you in a very effective and efficient fashion. But we are in a time where, I don't want to say disinformation or misinformation. Those are obviously buzzwords, but we're in a time where you can find anything to support whatever opinion, essentially, right? And you can find it somewhere.
Even in studies.
Right. I mean, certainly in specific kind of studies. So it becomes a question of the wealth of content, what you are willing to absorb, right? And who are your trusted advisors, essentially, right? And that comes down to, in medicine, do you trust your doctors? Well, how do you know which doctor to trust? And that's not an easy question. I think that's a question. Sometimes we try and find a quantitative, a numerical answer. If you find X, Y, and Z, this is the right person. I don't know that that's true in medicine. I think that medicine has to be a little bit of an instinctive kind of connection, right? If you walk into a clinician's room and they're just talking in a way that you find relatable, that's probably the right person. Now, that's not a perfect answer either, because as you said, there's a lot of snake oil salesmen, people that are willing to talk to you in a way that is very reassuring and reaffirming to certain beliefs that someone has. And it's not necessarily the best form of medicine. But you're right. The influx and overload of information allows people to kind of go in every which way. And it's hard to find a reliable form of medicine. And to some extent, that's what I'm trying to do here, right? I'm trying to have a very tempered approach to how we practice medicine. I've said this a couple of times already, like, in my wheelhouse, when people come in, right? And just for a classic example, someone comes in and they're concerned that there's an ear infection. Kid has an ear infection, right? Okay, so I've made a diagnosis of an ear infection. What's the worst that happens if you don't treat it? And I always say, well, the reason we treat an ear infection is because you're afraid of mastoiditis, which is inflammation of the bone behind the ear, which if that becomes infected, that requires surgical intervention. Meningitis, people are familiar with, right? That's when it gets to the brain and the meninges and it causes a central infection. Obviously, very concerning and can be very hard to treat. Critical, right? So I always give the ramifications of not treating a medical condition. And then depending on how the patient has presented, I give them the treatment plans, A, B, and C. I think there's generally more than a singular pathway for almost every patient, at least once again, in the way that I practice medicine. But you have to have that honest and open conversation. When what we tend to do, especially when you get tired, right, and you have maybe a tough customer, is we tend to get super concrete about things, right? This is what you have to do. This is, no one's receptive to that, right? When you start demanding a treatment pathway, that's when I think you tend to lose the patient, right? And that's when you lose the connection at the same time. Yeah. So it's definitely tough. It's definitely, there's no one answer. There's no, I can't give you a quick clickbait here. This would be great. How to find the right physician, right? In 3 easy steps, but there's no answer there. But that's really what we're trying to do in this forum, is like provide people with valuable content, a tempered approach, and to meet to some extent personalities, right? Like, going back to what I said before, no one cares how much you know until they know how much you care. If you're not having a conversation about how you take care of people and why you take care of people and what motivates you to take care of people, then it's very reasonable for a patient to have a very sterile, very cold approach to coming to a clinic and practice and ingratiating any advice that a provider gives them if it doesn't feel very personal.
Do you find lately to spend more time on educating a patient about the misnomers they have? So now that you created a scenario where they feel very trusting of you and they feel comfortable, now they're going to start asking you all these things. They're going to allow themselves to be more vulnerable and tell you the things that they do for whatever conditions they came in for. And then you spend a lot of time on educating them to make space to allow them to receive the information of what you recommend.
So that's a good question. I would say that there's a couple different pathways that I see with that, right? So there's the alternative method that is in the short term harmful and very quickly harmful. So those are the things where it's like, oh, someone said that I should drink bleach. Don't drink bleach, right? It's as transparent and as quickly as possible and as absolute as possible, discouraging behavior that someone thinks maybe is alternative, but the acute harms are as clear as day. I mean, there's very little room to negotiate because you're trying to acutely save someone's life from making a big mistake based off of something they heard. Then there are probably ones that are a little more nebulous, more ambiguous, more confusing, right? They're in a middle pathway. It's, I was told to, put something in my child's diaper. If they have a diaper rash, it might go away. And it's like not harmful per se. Right. I there's no evidence behind it. I don't know that it's efficacious. It maybe creates more of a cleanup later, right? But those are where I try and be more reasonable, and I try and meet someone where they are and be like, oh, I really don't know much about that. I'm almost interested. Sometimes I'll do a lookup and see if there's any source of any scientific basis, and occasionally I guess I can't think of something offhand, but sometimes you'll find some reasoning, right? Perhaps. And then there are the ones where, I guess someone is doing an intervention and I don't think I can acutely sway them. It's not acutely harmful, but I'd like to kind of maybe bring them back into more of a traditional pathway and give them reasons why I think, I don't know if I don't know if that's the correct method. Maybe let's stick with this way, and let's see if this, or if, if there's time to play, you can try that. But if that doesn't work in a couple days, try this. Once again, I think a judgmental, confrontational approach is just not a productive approach. And medicine's an evolving sport at the same time, right? Like when I say that we practice evidence-based medicine, we do, right? And part of that is taking into account a person's personal beliefs, right? And then more than that, right? There's recognizing that in 10 years, there's probably something I'm doing right now that in 10 years, they're going to look back and be like, well, why did Dr. Gilden do that? That made no sense, right? But I don't know that in the present, and I can't identify which there's some that I kind of think about occasionally. There are some things I think about that I'm like, I don't know. I feel like this is going to be very archaic and very outdated in 10, 15 years.
Do you have an example?
Well, I feel like this all the time. I hate when someone comes in with a laceration, someone comes in with a cut. And, I always try, and if it's a kid or it's an adult, I've always felt that it's so ironic. Let's say someone comes in with a cut, and now they need 10 sutures, right? So they hurt themselves. So what do? Unfortunately, I've got to clean the skin, and now I've got to stab them, unfortunately, with a needle to numb up the skin. And I've got to multiple times use this suture material, which is another stech and a stech, a stick and a stick, right? Until I get it closed, neat and clean. And I do as beautiful job as I possibly can. I want it to look nice cosmetically. I want it to be effective and hold, obviously, depending on what the body part is. But the irony, and then sometimes they need a tetanus shot. So now they get another separate shot on an arm. So someone cut themselves, and the ramification and the treatment plan is you're gonna stick them and stab them another 10, 20 times potentially. And once again, I'm careful, judicious. You try and be playful. You try and be positive, especially if it's a kid. You give them a lolly. You figure out all the ways that you can take care of someone in the best humanistic way possible. But at the same time, the ramifications of getting cut is getting cut a million additional times, so to speak. So I've always, and I know there are treatment modalities that they're already starting now, but I've always felt that is one of the most ironic things to the human medical condition,
That's
for sure.
Yeah.
As far as, other, let's say wild diagnoses, right? So I think people come in and they're coming with an average eye complaint, and you made some miraculous diagnosis and have had something, in a time sensitive manner, gotten them to the right, ophthalmologist for medical treatment.
Yeah. An interesting one comes to mind is toxoplasmosis. Patient comes in, complains of blurred vision, a little teary eye, and a slightly reduced vision. Nothing else. And when I look in the back of the eye, he basically has a parasite eating his retina.
What does that mean? That's crazy.
Toxoplasmosis comes usually where you may eat undercooked food, meat usually, or you deal with feces, let's say construction, bird droppings, or you work on a farm where there's manure, things like that. Thank God it doesn't happen too often in this part of the world, but there are, on occasion, we've seen some cases like that.
For someone who I need to be better about seeing the optometrist, so I got to book an appointment. But what's the biggest misconception that you deal with about eye health?
That glasses makes the vision worse. Using glass.
That's not true?
No, of course not. But it makes sense.
Because I've had this story for a long time, and I've been lying, I guess, my whole life accidentally. But I always thought this is perfect for the podcast, actually. When I was a kid, all my siblings and I guess my parents both have eyeglasses, had eyeglasses. Everyone has eyeglasses. And I was a kid in the 90s, so you can date how old I am at this point. But it was cool. Everyone had glasses. You had different bespeckled glasses and different colors. And I guess they're cooler now. But at that time, I thought it was cool. Maybe it wasn't cool. I just thought it was cool. I was probably wrong. But anyways, I remember lying, which I'm sorry, I apologize. But I remember lying when I was sitting for that exam, and he'd ask me, and I'd be looking and squinting, and I had to figure out which ones I had to lie about, the letter or the number. And I probably got some small prescription. He probably did, what you did, which is just like, all right, this kid probably doesn't need, I'll give him a small script because he's trying to get something.
Ever since then, you've been feeling guilty.
And then I needed glasses, and I always thought, I did this to myself. So you're correcting that assertion that I'm incorrect.
The analogy I give is that you can't prove to me that ever since your mom put on little baby shoes on your feet, that's what the shoes made your feet grow. You can't prove to me that. It makes no sense of course the shoes didn't make your feet grow, but you can't prove me otherwise. So the same idea, oh, ever since I put on glasses made my vision worse.
Right. I always felt like it made you lazy and try less. That was my thought process.
Lazy
because if you have the eyeglasses on, it makes your eyes try less, so they're not moving as much.
Right.
But
Okay,
that might have been made up.
There's a lot of logic. That's the thing. That's the beautiful thing about having proper studies to verify those things. So simply what you do with your daily life, epigenetics, and influences how you're.
So what's epigenetics mean, just for?
Well, genetics is what you're made of and what your parents gave you. So if your parents both have glasses of a certain type, you have a higher propensity to have that prescription.
Higher likelihood you're going to need it. Okay.
And but also it's what you do with your environment. If, let's say, your parents were avid readers and you're going to work the farm and not be a big reader, then you're less likely to have their type of prescription or a lower number, or maybe nothing at all. The body adapts, at least the eyes adapt to the environment. But if you're, let's say, a studious person and both your parents never needed glasses, and you're indoors, and there are other factors for influence of the environment, then you're more likely to be nearsighted. Mm-hmm. So it's what you do with your environment. But we live in a fixed moment in time saying, okay, this is how my eyes are now, and now I have this prescription. Oh, so now you know what the number is. Oh, so ever since I got this number, it increased. So you automatically use that as your goalpost, that it gets worse based on your prior. So it's a thought process that makes you automatically think that, the glasses makes it worse because every time I get a higher number, the numbers go up.
Mm-hmm. Yeah,
so people deprive themselves of proper vision.
Because they think that if I get glasses, I'll need more glasses, it'll get worse, and it's going to get worse, which is what I've thought up until this moment. So thank you for that. But if you don't mind reviewing the number system, because I know -4, -5. To an average person, I walk in and someone's like, "What's your prescription?" And I just like, negative. I just don't even know what to tell them. I walk right out of the store. Right. But what are the what's good, what's bad, what's small, what's high?
Right. So plus or minus 2 is considered mild to moderate, and then
when is it plus? When's it minus?
So -2. Let's say if you're nearsighted. So if you're nearsighted means -2 means that your natural perfect focal point is at 50 centimeters. So 1/50 is 2. So that's how they came up with the numbers, dioptric power. Once
again, these terms roll off your tongue. And dioptric?
Diopters. The terminology for...
No one's going to come to me as a doctor anymore. They're going to be like, this guy has no idea what he's talking about. He doesn't know what dioptric is. I still don't know what dioptrics is. But okay, fine. Yeah,
So if someone is nearsighted and they can see at 50 centimeters away, roughly around, I would say 18, 19 inches away, then they probably need a -2. And then actually, I can kind of figure out someone's prescription without having to use any devices. So if someone, let's say, they say they can't see, so I cover one eye because you have to test one eye at a time. Otherwise, you don't know. So for instance, and I can also tell that someone is nearsighted or farsighted because someone who's nearsighted needs minus glasses. And a way to think of that is that your eyes are too strong. So you're naturally, because it's too strong, you see very easily at near. So now we have to give you minus power to make you see properly at distance. Now, if you give too much minus power, then you won't be able to see at near. So you have to give just the right amount of minus power so you can see properly at distance without obstructing your near vision. So that's a way to think of it. Another way of thinking of it is that, back to that old diagram that I did, think of the eye like an egg sitting on its side. So that you've always seen an egg short or egg tall, right? Yeah. Long. So an eye that's really long means that the light coming in through the pupil, through the cornea, through the lens, focuses over here, and you're supposed to focus in the back of the eye, the retina. So you have to give minus power, so the light rays diverges enough so it can bring the focusing point over here. So this is a long eye, a myopic eye. So you don't see it in the front, you see it in the back. You can actually measure someone who's highly nearsighted to have a few millimeters longer eye in the back. And someone who is farsighted, they have a short eye, it ends over here. So that's just an idea.
So it's an oval eye, essentially. What we see in the front is a circle, but if you go back and
it's really more shaped like an egg on its side. Yeah.
Okay.
Yeah. So
hence your circle is not a terrible circle.
Right. Exactly. So if you're very farsighted, it means your eyes have to squint. It has to fatten the lens to bring the focal point over here, where naturally most people's are over here. So this is, let's say, normal. This is nearsighted eyes, and this is farsighted, shorter eyes. So you have to give them plus. You have to give them magnification to allow the natural focusing to happen over here, so they don't have to squint that muscle and use that accommodative muscle to use it naturally at near, where they need that extra zooming ability. So it's a beautiful, complex structure. Yeah.
I guess these are all the things that scared me about an eye when I was going through medical school. So I guess just from an educational standpoint, there are a whole bunch of medical conditions that I see from an urgent care perspective and sometimes an emergency medicine perspective that I think are, a bunch of people don't, you have an eye condition, you get very nervous. Is this, no one wants to lose their sight, so they go to see a doctor. It can be very nerve-wracking, and sometimes without knowing the particular signs and symptoms, you don't really know what you have, right? So if someone has one pink eye, could look like another pink eye, and one pink eye is simple conjunctivitis or an infection. Another pink eye, like we were kind of referencing a little before, is glaucoma, which requires a surgical procedure and medical management, right? And sometimes it's not even so easy to necessarily know the difference between them. So if you don't mind being our expert here and giving us a little bit of insight, I would like to run through the classic bread and butter urgent care complaints, and you give me your perspective on them. And then, if we can go through the eye emergencies and maybe the absolute, if your eye is X, Y, or Z, come see a doctor and go to your local optometrist, ophthalmologist provider as soon as possible. So, what's a sty? I hear people talk about it. I think that's the common vernacular, the common word for it is a sty.
Right.
What is it? How do people get it? What do people do when they have it?
Well, in a very simple terms, it's basically a glorified pimple in the eyelid. And the eyelid actually...
Gross.
It's just a clogged gland to make it not as unpleasant to hear. Mm-hmm. But the eyelids has a few different type of glands. And those glands have a very supportive role in keeping your eyes moist and lubricated and stable. It's just the tears itself is its own specialty, and how it's not just plain tears. It has many different components to it.
There's a tears specialist out there.
Oh yeah, big time.
Wow.
Big time. We all suffer from dry eyes, more so because of our lifestyle. Looking at screen time, it inhibits our blink reflex, our quality of life. We don't consume the proper food. We don't sleep right. So that
food affects the lubrication and the wetness of the eye.
Yeah, the diet definitely can impact quality of tears. Yes. Eating proper omega-3 foods.
That's like in your fishes.
Right. Flaxseed, cheese
I think I made the classic grammatical mistake where I said fishes just now. So it's in your sardines. Or
there you go.
Fish.
Yeah, the quality, high quality fish and other nuts and olive oils. That really makes the tear film better. And
there's good evidence to support those kind of metrics and measures.
There's definitely significant evidence, and to go for a natural approach, diet plays a huge role. But that diet plays a huge role in other factors as well, and that's easy to say. It's hard to apply on a regular basis, but it's not just diet. It's also sleeping properly, exercising properly. All these have impact to control inflammation. And a big portion of dry eyes is inflammation. So specific to the eyelids and styes, the glands get clogged. It causes inflammation. And sometimes it turns into an internal hordeolum, which is the swollen inflammation inside the eyelids. And in a few occasions, it can spread into preseptal and orbital cellulitis, which you would need oral medicine to prevent any infection into...
That's the skin infection that's around the skin of the eye.
And it can go behind
further
the eye
back, which
to
would
brain.
be more dangerous.
Exactly, right? Yeah. Thankfully, we don't see too many of those, but we see a lot of people with styes, and they're complaining why their contact lenses don't work. Contact lenses is like a sponge; it absorbs all the water in the tear film. So you have to have good quality tears in order to have comfortable vision. And speaking about the horrible drawing that I did before with the cornea, there are little micropores within the cornea. So a piece of glass or lens that you have is nice and smooth, but our cornea is not always perfectly smooth. There are little crevices that has to be filled up with the tear film so the tear film actually plays an optical role. Proper tear film plays an optical role to have stable vision.
As far as because you were mentioning the vision with the sty, and it kind of just popped into my head. I think you were mentioning how we're looking at our phones and the screens, and the first thing I was thinking about is what's the deal with the blue shade,
filter.
the blue light. You have a phone
Right.
or screens, and you turn it on, turn it off. What is the effect of this?
Right.
What's the evidence behind it? Because I'd be remiss if I don't ask you the evidence. You obviously these terms down
Right.
very very well, and you have the evidence in your back pocket. So if I don't ask you these questions,
Right.
I'm obviously gonna regret it.
So it is a little bit of a controversial topic because there are some studies that shows that having blue light blockers really helps your dry eyes, your ocular migraine. There's a term called computer vision syndrome, but there are also other type of studies that have been shown that it really doesn't have the blue blocker filters, doesn't really impact your dry eyes or chronic migraines or computer vision syndrome. In theory, they say that the blue light can steal your melatonin level away and impact sleep. And in the retina,
Lower melatonin means it's harder to fall asleep.
Right, hard to get a proper type of sleep activity. So based on my last read, it doesn't seem like blue light blockers do much to impact to impact your.
We're going to get a lot of angry emails from blue light companies, I imagine.
Probably.
We haven't put out an email address, so we'll be okay.
It's not my personal opinion. It's just what I read recently. Sure. People who stare at a computer constantly, they tend to get certain headaches, certain dry eyes. So when you and I are engaging in conversation, we're blinking 12 to 15 times a minute. But when you're focusing on something, and usually you're focusing on a screen, you blink 5, 6, 7 times a minute. So you're decreasing that blink reflex rate, and then the tear film doesn't have a chance to reset. Every time you blink, you reset the tear film. There's like 3 different layers of the tear film: the lipid layer, the tear film layer, and there's the mucin layer, the protein layer that keeps the, like a cell, there's the lipid phospholipid bonds type of thing. So the tear film creates its own type of stability to have a proper focus. So when you don't blink as frequently, and we're constantly staring at the same fixed distance constantly, it can cause headaches. So you're converging constantly. That takes a lot of strain. You're not blinking as much. And the same thing with the blue light. You're getting a lot of blue light, not as much as it used to be with the cathode ray tubes. And now we have other type of LED quality screens, so it's not as impactful. But there is such a thing where you get strain and migraines related to looking at electronic devices. But so far, based on recent studies, it doesn't really, they're contradictory in whether it's effective or not.
So that's called computer
vision syndrome.
Computer vision syndrome.
So we say the rule of 20. Every 20 minutes, get up, look 20 feet away for 20 seconds. Simply put, give yourself a break, find balance in your life.
So that way your eyes are looking in the distance, they're reformatting. It's a reboot, if you will.
In a sense,
Reboot, refresh. It's an F5 on the keyboard of your eyes. Okay, fine. Let me refresh this question. So we spoke about styes, and that's a pimple essentially for all intents and purposes in the eye. Now there's something called a chalazion. Chalazion, right? And that's different than a stye. How's that different than a stye?
Right. So going back to stye, I made it very simple. Sometimes styes can come from based on the skin type you have. People who have acne rosacea, fair skin can have certain type of skin styes. Sometimes people can have clogged tear ducts, eyelid ducts, because of, in a sense, they have lice on the eyelashes. There are specialty lice, just like you have lice on the scalp. There are specialty lice that, unfortunately, if we look at out of 10 people, majority of the 10 people will have some evidence of it.
Oh, no.
Yeah. So when you have an infestation, it can really cause a lot of eyelid infections. So there are different reasons why we get those things. So internal hordeolum and external hordeolum is the proper medical term for people who have styes. External hordeolum is the styes that is outside the lids on the outer portion, and internal is inside, and those are also impacting different glands. And when the infection went away, but the material leftover discharge is there, but there's no infections, there's no pain, just a lesion over there. That's called the chalazion. It's just collateral damage of the the infection that happened. And that takes a little bit longer to get rid of. And after a good amount of time, if it's not resolved, you can do some kind of surgical intervention to remove it. But with proper warm compress, continuous warm compress, and usually dry warm compress, because wet gets cold quickly, it really can help accelerate the healing.
And what should someone do, I think, from a treatment standpoint for styes?
Usually goes away by 7 to 10 days. Maybe the first 2-3 days it gets a little bit worse. The next 2-3 days I find that it stays around the same. And the last 2-3 days it resolves on its own. But of course, if it gets significantly worse, severe pain and inflammation, and you see it spreading throughout the eyelid, because the stye is usually localized in the one area. Yeah, there's a little redness around it, but if it spreads throughout, then you definitely have to step in and come into the eye doctor, ophthalmologist, or optometrist. Well, usually if it's severe, we have to give you oral medicine, because no matter how much antibiotic drops or ointment you put on that eyelid, that ophthalmic antibiotic ointment or drop doesn't really do a good job penetrating the eyelid, even though it's right there.
What's blepharitis, and how do you treat it?
Yeah, so blepharitis is essentially a lot of skin exfoliation and remnants on the eyelashes. And those cause a lot of localized inflammation, because now the staphylococcus, the bacteria, can grow and cause styes, infections, and dry eyes. But also blepharitis can be categorized as Demodex, which I mentioned before about the lice on the eyelashes, which a lot of people have. And if there's an infestation,
you're going to panic a lot of people right now when you tell
so
them.
maybe we should edit this part.
All right, but yes, people. All right, so people can get it from that. What else? What else is blepharitis, and how do you
essentially you have to do proper lid hygiene. Most people wake up in the morning, if they wash their face, they brush their teeth, but they don't really do a good job cleaning the eyelashes. The eyelash is like a very fine tooth comb where they're so close to each other that material gets stuck. It's embedded, and it's usually at the base of the eyelashes. It's really hard to get rid of. So you really
There's no toothbrush for the eyelashes.
Actually, in today's day and age, you can find a lot of things online.
All right, gotcha.
Whether it works or not is different stuff.
Gotcha. Okay.
But yeah, essentially, just take a little bit more. Don't be aggressive, but take a little time to clean those eyelids, eyelashes, especially if you're complaining of recurrent styes or dry eyes.
So gentle cleanser for the eyelashes to prevent And if someone has blepharitis, what do they do for it? What's the treatment pattern?
So depending why they have it and what type of things they have, you can buy special over-the-counter lid scrubs that's designed to soapy antibacterial soap that is designed to go in the eye. It's not going to damage the eye or hurt the eye. They can clean that. Or just take that wet, warm towel, let it sit on the eyelash, soften up that material debris, and clean it. But if doing it simply frequently, if someone has very, very dirty teeth, they can't just decide to clean it aggressively one day. It's continuous cleaning. But some people are more vulnerable than other people related to that.
That's, and it generally just looks like this redness across the eyelid, either upper or lower.
Yeah, it's really hard to tell. You really have to look under microscope to see what kind of blepharitis you have. There's different categories, and so if they're having chronic issues, definitely come in, have your eyes checked by eye care health provider to determine what the cause is.
I think probably the most classic complaint from an eye perspective, and correct me if I'm wrong, conjunctivitis, right? That's your classic pink eye. Multiple causes. It could be from allergies, bacterial infection, viral infection. If I remember, we were speaking months ago. You said something about vernal.
Oh yeah,
care,
yeah.
Which
that's a bad one.
That's a bad one. But can you just go through each the classic causes? What's the treatment plan for each one?
Right.
Presentation.
Right. Yeah. So the pink eye. Everyone says pink eye.
And they say that because the eye looks pink, so it makes it simple. It's a straightforward diagnosis.
Yeah.
You don't need to go to eye doctor. It's pink eye.
There you go.
Yeah.
But there is a certain subcategory, specialty of pink eye that's really meant for pink eye, and that's the highly contagious one. Thankfully, I don't see too much of that. But most red eyes, which is the white part of the red eye related to infection, is due to a viral conjunctivitis. And in this day and age, with so much medical technology and so many treatment plans, there's no proper protocol to take care of a viral conjunctivitis. So sometimes the doctor will give you an antibiotic. The antibiotic doesn't really kill the virus. However, we give it to prevent a secondary infection, because it is possible while you're fighting one infection, you might be prone for a second infection. But usually it takes its course and and heals and resolves on its own. So most pink eyes that we call, red eyes in general, they're viral conjunctivitis. Of course, if we have bacterial conjunctivitis, they're more likely easy to take care of with antibiotics. And with in general, there's a very big overlap between. But in general, if someone has a red eye, and it's virus related, they don't produce as much mucus. Sometimes they do. They just produce a lot of tearing. But it's very dangerous to self-diagnose, because sometimes that feeling that they have a viral conjunctivitis could actually be a problem inside the eye called uveitis, inflammation, which has very similar symptoms: sensitivity to light, tearing in the eyes, red eyes. So or it could be acute angle closure glaucoma, where the short eyes, where we mentioned farsighted eyes, the iris and the cornea are so close to each other.
Yeah, we'll do that one shortly.
Yeah,
We'll go over.
and they close up, and to prevent the liquid in the eye to drain, so they get a high eye pressure, and that could be symptoms. So it's very, very important to, if you have a problem and you feel like something is different than usual, don't.
What's allergic and what's vernal? And I don't think I'm pronouncing that right, but I'm saying it.
Yeah. So allergic conjunctivitis is allergies to the season, and vernal is a more severe type.
How do you treat the allergic? How do you identify it? How do you treat it?
Yeah, so I don't know how technical you want to get. They're inside the eyelids, on the inner part of the eyelids, and there's you can see papillae, or you can see follicles, and based on what you see more of inflammation, it would be an indicator if you have viral infection versus the allergy. And when you flip the upper eyelid, and you see these big cobblestone type of inflammation, which is really hard to pick up unless you flip the lids, then you know, oh, okay, this is a more severe category of allergies on steroids, and that's harder to treat. And ironically enough, it's on usually young boys. They sometimes grow out of it, but it tends to be more in the male population before they're teenagers. That's what I usually find them. That's
allergic, or
vernal is like a category of allergies. Yeah.
How do you treat like your average? We're in the middle of the allergy season. By the time this is posted, it's probably gonna be through and not helpful to anyone, but maybe getting them ready for next year. But what's the treatment for like your allergic conjunctivitis on average?
So usually a drop works well, and it can be a histamine blocker, other types of mast cell stabilizers. But the trick that I try to tell the patients is that don't treat it when you're symptomatic only, because then it's so inflamed and so red that the very gentle allergy drop is not going to be so effective on such inflammatory. But if you have to continue doing it throughout the season that you have allergies, and if you continue every day, it might not even come out. So being proactive, between Passover and Shavuos, this is the time I'm getting allergies. You know what? A week before Pesach comes out, but a week before the flower starts budding, or the grass pollinates, or the tree pollen comes out, start taking the drops. Throughout that whole time period, you'll find that it may not even come out, at least for the eyes. Of course, if you have other sinus issues, then you should take something.
So if someone has allergic conjunctivitis, what would be your recommendation for a treatment plan, and what should they be aware of?
Right. If they come in severe with huge amount of itching and they can't control their itching, burning, tearing in their eyes, and it's diagnosed as allergies, then we start off with the steroid drop to have that immediate impact to calm that inflammation on the short term. And while they're taking that steroid drop, they're starting the allergy drop. That's more of a gentler type of drop. So then when we taper off the steroid, they should continue with the allergy medicine throughout the whole entire time. And if they stop too early, then it can come back, it can rebound. So it's important to really continue taking. And I get it. No one likes to put stuff in their eyes, especially when they're not symptomatic. But you have to go beyond that and recognize that if you don't do that, then it's just you have to repeat the same process.
It's a common theme in medicine, just for a small digression, and this came up with, we were talking with Dr. Mann about podiatric issues. And so many times you cure the symptomatic disease component of the disease without fully resolving the disease. But from a patient perspective, and it's very normal and very reasonable to understand, the second the symptoms are gone,
they stop.
done, right? Because, I went to the doctor, I had an issue, they solved the problem, and now I'm done with the medication. And it's sometimes so hard to impart the value of completing a course of therapy. I'm guilty of it recently. My son has a simple impetigo or a small skin infection. And I think, I think we stopped halfway through. I stopped putting the antibiotic cream on. I stopped the oral medication. And, it looked like everything got better, and boom, after a few days, he's got multiple spots back. And it's just because it's human, it's instinctive, but it's, I guess that's what makes it all the more important that, you take the extra second and explain that just because something symptomatically is improved, it doesn't mean that the entire disease process is completed, right? That you've rid the patient of the entire medical pathology, and they're good to go, and they don't have to continue and finish out the course of the medication. So definitely a good, important point to bring up.
Yeah. And unfortunately, at times, if you don't complete the course of medicine, the next time you have to treat it, it may not work because either, whatever infection you have, it can mutate, and you have to change it to stronger medicines. So,
it's another disease that is certainly alarming when someone sees it, So we've gone through the redness of the eye, the various types of relatively benign, but, urgent care level complaints that need to be taken care of and remedied. What happens when someone sees like blood in the front of their eye, like a subconjunctival hemorrhage? I found that there's generally a lot of panic associated with it because it looks like the eye's bleeding.
Right.
Where does it come from? How do you resolve it?
It's very scary. It's very visual. It's a scary look. And it's one of those, I would say, of all the diagnoses that a person has in the eye, is the least concerning. It's the most visual, the most impactful, the most scary, and it's the least concern usually. Mm-hmm. So the white part of the eye is not truly always white. They're little tiny, thin, fragile blood vessels. And those blood vessels can rupture for various reasons. Maybe you got some kind of hidden eye so lightly you may not have realized. Maybe you rubbed the eye. Maybe you sneezed. Maybe you were constipated and had trouble going to the bathroom. Maybe you're taking too much blood thinners. Maybe your supplements, can cause too much of that. A certain, like high dosage of even omega-3, overdosing on that, or garlic.
Subconjunctival hemorrhage, right? So I've noticed something that a patient comes in panicked because all of a sudden the white part of their eye, they see blood, right? Why is my eye bleeding? It doesn't look good. But oftentimes there's very little to do from a treatment perspective. So what's your insight onto what causes it, and what's the treatment pathway?
Yeah, so usually it's a blood vessel that ruptured for various reasons. Someone lifted something too heavy, someone sneezed so strong, they held it in, and then, indirectly they popped a blood vessel. The white part of the eye, the conjunctiva, has many, many tiny little blood vessels that are very fragile. It doesn't take much for them to rupture. Sometimes it's caused for other things, some blood disorders, and sometimes when people who are elderly, they're on blood thinners for life-saving medicine to prevent any strokes or heart attack, it can cause that subconjunctival hemorrhage. Of course, if it reoccurs, we have to speak to the doctor that prescribed the medicine to see if we can reduce the dosage. But obviously, they're on it for life-saving medicine. So if they have it, usually there's nothing you need to do about it. It looks very visually obvious, but it resolves on its own, usually within 7 to 10 days. I had once a case in a nursing home. It was so significant that the blood was actually coming out of the three-dimensional. It was purple and was coming out of the eye. And maybe I should skip this part again. But so I was thinking, okay, maybe this is a case where we need to do some kind of intervention. And sure enough, a week later, it was like it never was existed.
Just went away on its own.
It reabsorbs the body.
That's obviously a severe case and a severe example.
Right.
But
and usually you shouldn't have any visual obstruction or pain. Maybe you'll feel a little bit of discomfort because there's actual blood pooling in the area. And with gravity, it pulls it down. So it might actually look worse the second or third day, let's say if it's superiorly. But again, if there's no pain and you actually see hemorrhage in the eye, you don't have to do anything usually.
One of the bread and butters of urgent care and emergency medicine is corneal abrasion, right? So from my perspective, the cornea, the outside of your eye, the abrasion, something rubbed up against it caused a little bit of a boo-boo, for a technical word there, boo-boo, by the way. And for what we do, we tend to put some numbing medicine in the eye. We evaluate with that blue black light, right? And then we see this with the fluorescein, you see this massive or small green glob in the eye. But that's my perspective. But corneal abrasion, what is it? What do you have to do to treatment? How do you find it?
Right. So the cornea is not just optics to help you focus in the back of the eye. The cornea has many different layers. So usually with corneal abrasion is the epithelial layer gets scratched or gets peeled away for various different reasons. And that dye that you put in, it actually stains the area that to see how significant it is. And that's important because sometimes it's not an abrasion, sometimes it's a herpes lesion. So seeing the pattern on that fluorescein dye is very important because it can look the same.
But right. Generally the training is, when it's herpes, it has, you can have these little lines, right. Little dendrites that kind of come out. Which looks like cracked glass, if you will, from the middle.
Right, exactly. Depending if it's simplex or zoster. But yeah, exactly. And of course, the treatment would be completely different. With a corneal abrasion, depending how severe it is, if it's very severe, we can put a bandage contact lens, essentially a bandage on the eye to help with that pain because there's so many nerve endings, sensory pain nerve endings on the cornea. It hurts so much. And it looks to you like a little scratch, but that patient can be in severe mm-hmm. pain. So depending how large it is, you put a bandage contact lens. You, of course, give prescribe antibiotics. And it's controversial, but, some people do, some people don't. Eye doctors do. They, depending on the type of abrasion is, you give a steroid too, because the cornea has the peripheral part of the cornea has a lot of stem cells, and it can heal very, very quickly. And if it heals too quickly, it's kind of like a cake that's not fully baked on the inside. And unfortunately, it's a high reoccurrence rate. When someone has a one-time corneal abrasion, they can have a recurrent corneal erosion, a recurrent corneal abrasion, because that epithelial cell didn't fully penetrate into the stromal layer, the deeper layer, to entrench itself, that even though it's sealed on the outer area, it has to penetrate deeper inside to prevent a reoccurrence. So giving a steroid first helps with the comfort and the inflammation, but also helps slow down the healing process, because to heal too quickly sometimes is not good.
That's interesting.
Yeah.
You mentioned the contact bandage, and it's funny because I think one of the first interactions we had working together was I saw corneal abrasion. I probably sent you a photo like, hey, it's a serious corneal abrasion. I'm a little bit worried. I kind of want you to follow up. And you said, yeah, send him into the office tomorrow, and we'll put a contact lens that's protective. And I was like, I have no idea what this guy's talking about. I've never heard of this before. We give the antibiotic drops, and we have him follow up with an eye doctor. And I think you saw the patient. You said, yeah, put it on. Guy felt great. And,
right.
Because for me, the other thing that I try and do from an acute care, urgent care, emergency medicine standpoint, because the pain, I try and take the pain pretty seriously. I imagine most of the things that I've not felt personally, but I know about medically, are relatively uncomfortable. And I don't want to underrate the level of discomfort that it is. I tend to give someone a small amount of that numbing medicine because it's the most I can do. And I know there's controversy between ophthalmologists and emergency medicine practitioners about, the safety efficacy of sending a patient home with it. So I usually give a little small amount, which I think, I hope universally more or less people agree is relatively safe. And just to give them a pain relief for the next day or two, I guess this is a more effective fashion that's not in my, my toolbox, so to speak.
I've seen how much you give. You give only a few milliliters, and that's the perfect middle approach, where they can't just go home with a whole bottle and self-medicate, which is so dangerous for the long term.
Put it in the cabinet for a later time.
Right.
Hold on
this
to it
is
for
good
a couple
stuff.
Years.
Yeah, exactly. So
absolutely.
it's so smart to give just the right amount until they're taken care of. So that's really a great approach. Yeah, people.
I squeeze it out in front of them to make the point too. So I'm like, I got to squeeze out most of this bottle, because I know it's good stuff. But yeah, that's what I try and do there.
Yeah. So when I do put on the bandage lens, they feel immediate relief, because they come in sensitivity to light, major headaches and pain. They have to wear the tinted, very deep, dark sunglasses, and even emotion won't really alleviate that. So putting that lens, it gives that immediate relief. And it's not just a regular lens. It has to be a special type of lens where it allows the oxygen to penetrate the lens. The oxygen permeability has to be high enough that they can sleep with, because it's not just that they're wearing a lens, the eyelids close on top of the lens. So if there's not enough oxygen, then you can cause major secondary infections or other issues. And so sometimes when it gets really complicated or reoccurs, we tell them to put an ointment at night so the eye stays lubricated, the eye stays healing, even after it healed completely, even 30, 60 days afterwards, to prevent reoccurrence. Sometimes the stromal layer, the deeper layer in the cornea, becomes so swollen that the epithelial layer cannot heal properly, and their vision changes and they're blurred. So you have to give them, in a sense, salt water for the eye, just like you salt meat, to take out all that extra fluid so the cornea can become less cloudy and clear, because when it fills up with water, it becomes cloudy. So it really impacts their vision, and depending if it's peripheral or central. But yeah, so that's a whole specialty within itself.
It was fascinating. A couple things are fascinating, but what you mentioned earlier about the steroid to kind of slow the healing, so it heals appropriately from underneath first, and then on the top.
And that
layer.
could be controversial as well. So
we'll put a disclaimer on top of that. But
there
I
you
think
go.
in general, just from my perspective, people come to an urgent care and get urgent, emergent care for various conditions. And sometimes I'm able to take care of it so well acutely, but then I tell people to do the chronic follow-up, and it's almost like, well, he did such a good job. Why should I see that? And this is the answer, right? This is information you don't have on the front end, and that's what the specialist really provides for me on the back end, is like, hey, listen, I can take you out of pain. I can make this relatively safe, but I think they're the best possible care. The continuity of care is really seeing that specialist and having that secondary advice for how to treat this over the long term and not just the acute phase. And it actually segues nicely also into, everyone takes a schliff. Everyone goes to sleep with their contacts in, accidentally or purposefully. And, let's say 9 times out of 10, you get away with it, if not more. But what's the harms of people who leave their contacts in for too long like that? Handling their contacts with not washing the hands first. I think these are all great questions.
Yeah, so we're a victim. The contact lens technology has improved, and the comfort has improved so much. We've taken it for granted.
We're victims of our own success. Is that what you're going to say?
Yeah, exactly.
Okay.
So I guess an example I would say is that it's like driving without a seatbelt. We all know we're trained to put on a seatbelt, but hey, if we're just a block away, 2 blocks away, do I really have to put on that seatbelt? And thank God they have that ding, ding, ding alarm in the car. But if it wasn't there, maybe we wouldn't put on our seatbelts. So God forbid, if you were in a car accident and you don't have that seatbelt, you realize what the issue is. So you never know when that infection will come, but when it hits you, it can be so significant that you probably derailed your lifetime of wearing lenses. So for instance, if you were able to wear lenses for 5 years, and I usually see with the younger population, the late teens, early 20s, and they get that contact lens infection, their eyes are almost never perfectly the same.
What does that mean? What do you mean by it derails and your eyes aren't the same?
So it causes chronic inflammation. It causes ulcers in the eye. It causes opacification.
What's an ulcer in the eye?
Essentially, it's a bacteria eating away into the cornea and causes little craters, mini craters. And depending on where those ulcers are, they're peripheral versus central, even if it's healed, it won't heal always in a clear layer. It will be now cloudy. So imagine looking through a dirty window. Yeah, you can, but the dirty window is inside the window. You can't really clean it anymore. So no glasses or contact lens prescription will give you that sharp vision. And even more so is that the cornea has no blood vessels to keep it clear, to give you clear vision. But around the cornea, there are a lot of blood vessels. So if the body sees that there's an infection that it's fighting, and usually those ulcers come from contact lens overuse, then the blood vessels grow into the cornea. So now you pave the highway for blood vessels to access a clear cornea that's not supposed to have blood vessels. So even though it healed and it resolved the infection, every time you get a new infection, that blood vessels comes in quicker and it can go in farther. It's like paving the road into clear, untouched area. And that's great for fighting the infection. But every time it does that, it changes the shape of the eye, which can create induced astigmatism. Astigmatism just means 2 different curves in the eye. But it can distort your vision so much and cloud your vision so much that glasses, surgery, contact lenses will not give you that sharp vision. So it's not really worth to take that risk. Every now and then a person having an infection, not a big deal, but people who are chronic people who don't take care of the contact lens use properly, they overstretch their lenses, they sleep with them, they swim with them. Those are the ones that we're really worried about.
So, obviously a serious thing, corneal ulcer. Just to enumerate a couple other, high acuity eye conditions, just to for a little bit more education. Orbital cellulitis, we kind of touched upon it when you were talking about what was it? It wasn't the conjunctivitis, it wasn't the blepharitis.
A stye, a simple stye,
talking about a simple stye,
yeah.
right. So you were mentioning how that can be an orbital cellulitis. So if we can just go through it, orbital cellulitis, what is it? How does one get it, and what does one have to do regarding a treatment pattern for it?
Yeah, so thankfully it's not so frequent, but sometimes styes can turn into a very big eyelid infection. And if it penetrates posteriorly behind, then it can go quickly into the brain. There's no real barrier between the eye and the brain. And once it's there, it can cause the whole eye to be inflamed and potentially cause infections of the brain itself. So that's an emergency, and you have to treat that. Either oral medicine or sometimes, depending how severe it is, even IV. But thankfully, there aren't too many occasions. But overall, with a stye, if it's small, it's localized, it's a little uncomfortable, usually it resolves within 7 to 10 days.
We definitely, from an urgent care perspective, we see these moderately frequently, right? We see them, or at least questionable orbital cellulitis. And this is the complexity of medicine, right? Is that sometimes everyone would like every medical pathology, every medical disease to be concrete, to be clear and obvious and crystal as day. But unfortunately, sometimes, you look at an eye and you look at the bottom, you look at the top, and it's a little bit red and a little bit swollen, and you can't tell, was it irritation, or is it this, is it the start of a cellulitis? Is it warm? And sometimes you have to make a clinical decision, right? Do I need to start this child or adult on antibiotics? It definitely, from an urgent care perspective, it's the kind of thing we're dealing with maybe a couple times a week for sure.
Oh, really?
Wow. But, once again, it's one of those things where it's how much of it is the social factors, right? Like, well, what's my index of suspicion? Meaning, how likely do I think that this is cellulitis? What's the likelihood that I'm going to get good follow-up with these patients? Then you have to make a clinical conclusion based off of that, what your treatment plan is going to be. So definitely something we see to some extent, or at least we have to consider. Another, severe pathology that, I think, this is going to be one of the top 5 from this podcast is like, we'll talk about retinal detachment, right? So I think inherent with retinal detachment, which, just to reference that fantastic picture that you had up there before, the retina being in the back of the eye, and that's kind of like taking a picture of everything going on, and that's how you visualize. So retinal detachment is when that starts to go away from the back of the eye. I think classically, I think of flashes and floaters. These are the buzzwords that you learn. And I've certainly, in an emergency room or acute care, I use ultrasound, and that's kind of how I identify it. Right. But, retinal detachment, what is it? How do you identify it? And what is the treatment plan for someone who has retinal detachment?
Right. Yeah. So one of the symptoms is flashes and floaters. And there are a lot of people, just like styes, there are a lot of people always complaining of floaters. And if I communicate to a patient, more than half the time, they'll say, yeah, I'm symptomatic of floaters. So any sudden onset of floaters that you haven't noticed before, so you don't review back saying, oh, I got a floater. Maybe I should get maybe I have a retinal detachment. So no need to freak out. So any sudden onset of floaters or flashes of light or decreased vision, that's a good idea to come in to check the back of the eye to make sure that the retina is healthy. So the higher the number of nearsightedness you are, the more likely you are to have a retinal tear, hole, or detachment.
So just, referencing the egg, the nearsighted is when it's a longer egg?
A shorter
egg.
Right.
So you have the shorter egg eye.
Right, exactly.
This is a very in-depth medical podcast. You have the shorter egg eye. Yeah.
Right. Another way of saying farsighted is if the cornea is not too steep or the lens number. So there's multiple ways.
We're working with short eggs and long eggs here. Okay?
Right, there we go.
You have the shorter egg eye.
Right.
So, nearsighted.
If you're nearsighted, your eyes are longer. And what happens when your eyes are longer? Mechanically, automatically the retina gets stretched. And what happens with like cerebrorep when you stretch too far, eventually there are stress parts where you get tears or holes or detachments. So if it's a small tear or hole, depending on the severity, you can just watch it to see if the body doesn't really heal, but it seals itself down, because inside of the eye is filled with gelatinous liquid material, the vitreous, and that if the hole is open, that liquid can go inside that hole and in the back peel away and unzip the retina and detach it.
Right.
So if it's a hole that we're concerned that that's going to happen, then you can do a laser. And bringing up the analogy how you sewing up a laceration, that laser is basically essentially specialized burn marks. You burn healthy tissue around it to border it, to seal it down so it doesn't spread, to quarantine it in a sense, to seal it down.
Right.
So
the way I like to think about it, so the optic nerve is that's the nerve that is your visualization nerve, so to speak. And I'm going to be very simple here, so please don't correct me when I'm completely off base, but I'm just talking to people like me or simple-minded folks. But that optic nerve comes from the back of the eye, and it kind of forges into this retina, and that's usually attached to the back of the eye. But when that starts getting detached, right, and this fluid, almost like it's a curtain billowing in the wind and there's a hole in it and this fluid gets behind it, it could push that further forward, further detaching it. So what this surgery or this laser treatment is it kind of takes that curtain and tacks down, so to speak, that curtain to the back wall, so it no longer detaches more from the back of the eye.
It creates scar tissue to seal that down. So on occasion it can happen at the actual nerve, but most of the time it happens in the temporal, superior temporal area where the retina is super thin and they're just vulnerable for that.
So that's like the outer top portion of the eye. But when I once again, simple, but that outer top portion, I think that reflects inner bottom or something, that it kind of is the opposite.
Yeah. So everything.
So your vision would be.
So superior temporal would be inferior nasal. So you'll see an issue a lower portion. So the top part of the retina visualizes the bottom part of the visual field, and vice versa. Mm-hmm. So everything is opposite.
So it's weak on the outer top area, but the way someone might see that is inner bottom. They see a flash or a floater, and that's where it would present.
Right. But any type that you see a sudden onset of new type of floaters or flashes of lights or decreased vision, by default, even if you saw the doctor 3 days ago, you should come in and check that out.
So someone has we're gonna build a list here. Sudden flash, sudden floater, go see your doctor.
That's right.
Very acutely painful red eye, we're gonna go see your doctor. And I guess that segues us into the next one. We brought it up a couple times now, and I think glaucoma is probably one of those words that people are remotely familiar with because they've just heard it so many times, but not intimately familiar with. Like someone says they have glaucoma, and you're like, oh, that sounds terrible. They should go see a doctor about that. But you don't really know, like Aunt Esther has glaucoma. Oh, poor Aunt Esther. She has glaucoma. I don't know what that means.
Exactly. It's just a strange word. Yeah.
But what exactly is glaucoma? What are the signs of glaucoma? What's the treatment pattern for glaucoma? How does someone make the diagnosis for glaucoma? Right. They have acute angle, non-acute, less acute. What are the different options for glaucoma?
Right. So just going back for a moment for the retinal detachment, when someone sits for a long time and gets up, they'll also see floaters and flashes of light. So clearly that's a lack of blood flow. Mm-hmm. So, use your common sense, and not every time you get up, oh, I think I see that flashes and floaters. Sure. That you go run to
like when we get up after this podcast and we're lightheaded from sitting for so long and standing up. No, we don't have to see a doctor immediately.
Exactly.
We might have to sit down for a second, but you don't have to see a doctor immediately. All right.
So with glaucoma, it's just pressure in the eye. And a good analogy is just like blood pressure. Most people who have very high blood pressure may not even feel any symptoms until you measure them. So same thing with eye pressure. And it's a silent killer of your vision. It loses your peripheral vision. So when you have high eye pressure, it chokes the optic nerve that you were describing. That the nerve is basically the wire to the eye that sends the information to the brain to process the information. And when the pressure is so high that it chokes the optic nerve, you start very slowly losing your side vision. So slowly you may not even realize because you don't have a comparison.
So it's the peripheral, it's the outside. So, like if someone's driving and they don't see something that's, that blind spot mirror kind of situation, that's what someone would maybe not notice that they're losing if they have glaucoma.
Right. Now, we all have a natural blind spot because if you think of the nerve that's coming in there, that it punches a hole into the retina, that's the part of, there's no photoreceptor in that area. So that you can actually find your own blind spot. So that's a natural part. So, and if you are feeling...
In life, people have an issue finding their own blind spots.
Yes, it's very...
That's more philosophical. You're talking about more physiological, more... Okay, but go ahead.
Good point. Very, very good point. So it's really hard to... most people don't have enough high eye pressure to be symptomatic. And if they do have...
What's normal eye pressure?
Just like in everything else, there's no exact amount. The average eye pressure, I would say, is 15. But there are people who have pressure of 11, 12, and they have glaucoma. Because even though that pressure is low, it's too high for them. And there are people who have pressure of 25, 27, and they don't have glaucoma. And that's why it's important to monitor the patient over time to see if there's damage for that person. So, and glaucoma is not a one and done type of story. We can determine right away if someone has glaucoma. It's to monitor over time. It happens very, very slowly. So, of course, it happens more with the elderly population. You're more vulnerable when you're older. It's its own specialty. Just being a glaucoma specialist, it's its own category. So that's where, going back to AI, just giving us all that data input to figure out what are the parameters, what are the reliability of the data, what is the trend analysis to give us a final answer. Do we treat it? Do we not treat it? And even with glaucoma specialists, sometimes they're proactively treated before they even have any symptoms of glaucoma based on the patient. Or sometimes you use a drop to lower the pressure, or the patient's not compliant, or they don't have good insurance where they can't pay for it, or they have dexterity problems to put the drops in. There's glaucoma surgery. So they're definitely
specifically. Sorry to interrupt, but specifically for acute angle, what is I think the vignette that I remember from medical school and the one that haunts me to this day, and I always look when I see a patient with an angry red eye, it's one of the first things I'm thinking about. And so the clinical vignette is someone walks into a dark room and all of a sudden they have an acute painful eye, and you see them and they have a hazy cornea. These are buzzwords that I've been burned into my skull, and their pupil is mid and fixed, and it's not really moving much, and it's red and angry and painful. But from your perspective, what do you see on exam, and then what would be your treatment pattern for this patient?
Right.
So we have, here's regarding acute angle glaucoma, we have now a ping pong or some form of a circular shaped eye. And we have something that looks like a tablet, perhaps an amoxicillin tablet or something like that at the bottom. But anyways, we're talking about glaucoma, and what do I learn from these pictures?
Yeah, so remember we talked about nearsighted versus farsighted, short eye versus long eye, right? So here's a long eye, right, nearsighted. So you can see it's longer.
And that one is more subject to possible retinal detachment as well.
Very good, because it's longer, long. Stretched out. And
I'm learning something.
There you go. Very good. And because it's longer, it has more space for its anatomy. Over here, it's a shorter eye, so you can see that the pupil, the iris, the black is the pupil, is very narrow it's very narrow. There's not much space of it. So when you eye color here, can you just you want to? I'll let you draw it this time.
So if someone has blue eyes, so
there you go.
You're gonna tell me if this is. Oh shoot! I just messed up the blue. All right, let's see if I can salvage this. Is this correct? Did I do that?
Let's see. Yeah, I'll take that.
So it's on pupil and
right.
Blue color.
So what happens, like you said, if someone goes to a dark environment, the pupils dilate, but they dilate so much that they ruffle up and they get stuck over here. So this angle over here, where the cornea meets the iris, is an angle. That's the place where it drains the liquid in your eye. So when the iris
from the front part of the eye to the back part of the eye.
It drains exactly. Okay. Yeah, so it drains the eye.
If I remember, there was chambers. There's an anterior chamber and a posterior chamber.
Right, exactly. This is the anterior, this is the posterior, and the trabecular meshwork is right over here where the liquid drains away into the blood vessels. So when the irises dilate in the dark to get more light in, it clogs up, because anatomy mechanically it's so small, it clogs up the drainage area.
It's a plumbing problem.
Yeah, and then what happens is that the pressure builds up. Exactly, it's a plumbing problem, and the pressure builds up, and there's no place for the pressure to be relieved. So you get a hot, steamy red eye, blurred vision, and so that's a true ocular emergency, and we have to take care of it. And thankfully, I've only had 2 cases in the last couple of years. So the first treatment is oral Diamox.
What does that do?
It just, it's just a diuretic. It just flushes all the liquid of your body and indirectly to release that pressure. And we put a bunch of topical drops in the eye to also relieve the pressure. And because the cornea is so high, the pressure in the eye is so high and so steamy, you have to choose certain drops that would work and not work. So we have to wait till the pressure goes down to utilize other type of eye drops. And then in order to prevent that in the future, you actually can do a little hole in the iris right over here. So they have a secondary funnel system to drain.
That's called the iridotomy. That's the laser
exactly.
hole in the eye.
Right. And so
is it as scary as it sounds when someone's shooting a laser into your eye?
It sounds scary, but it's very non-invasive, and it's really you need a tiny hole. And usually they do it under the superior part of the eyelid to prevent any double vision. So either temporal, but it's a tiny hole. But sometimes people have double vision, so they make it on the superior part, so the eyelid covers up that tiny hole.
I don't think anything makes me feel like I live in the 21st century more than hearing people lasering in the eye. It sounds very futuristic that there's lasers being shot in the eye,
Right.
but obviously pretty critical for this kind of disease process. Now, a couple other things that are probably worth mentioning. What is a central retinal artery occlusion? How does someone get it? How does someone identify it? What does someone do to treat it?
Yeah, that's thankfully we haven't seen too many of those, but essentially the blood flow to the retina coming through the optic nerve is completely occluded. It's a stroke in the eye.
Stroke in the eye, essentially.
Yeah. There's central retinal vein occlusion, there's central retinal artery occlusion, there's branch retinal artery.
The artery is the thing that brings the blood to the eye, the vein away from the eye.
Right, exactly. And think of all these things as like a branch of a tree. The more bigger the vessel is before it branches off, the more damage there is. If it's a tiny plaque or obstruction, then it can travel further down. And once the retina is deprived of that blood flow, that's it. The tissue is dead.
How does someone know if they have it? Is it a painful condition? Is it painless?
With central retinal artery occlusion, they're completely lost their vision. They can't see anything. With a branch, they can say essentially the same thing as retinal detachment. They can say a part of my vision is missing. I remember a case where I had a patient who he said, I don't see the bottom half in my left eye. It's gone, and there's no pain. There's no other than a visual, and you won't even always notice it if you don't cover one eye, because with both eyes open, people don't realize which eye sees. So it's an issue. It's really, they need a full workup, systemic workup, blood workup. If I see a central, then they have to go to the hospital to make sure that they're not going to get a pending stroke. So because these blood vessels usually come from the brain, and they branch off, they have to check the carotids, and they have to get the cholesterol and the blood pressure under good control. So
it's one of those things that someone could step into an optometrist's office and, unfortunately it's a bigger matter that is multidisciplinary and kind of needs more emergent
definitely
care.
It has to be.
And it's painless, right? So, I mean, as opposed to something like we were talking about glaucoma earlier, which is a painful condition.
Well, acute angle closure is painful.
Acute angle, right?
Yeah. But a regular chronic eye pressure that's not too high, people won't even notice.
I guess one of the last conditions we should cover is something called optic neuritis. What's been your experience with it? How does someone get it? What would you be worried about if someone presented with a case of optic neuritis?
Yeah. So with optic neuritis, usually that just means inflammation of the optic nerve. And usually that's associated with MS. It could be associated with other things as well.
Multiple sclerosis.
Multiple sclerosis, okay. Right. It's just inflammation on the nerve or around the sheath around the nerve. And you can have reduced color vision. You can just have overall reduced vision. And sometimes you have fatigue or malaise or weakness or pain when you move your eyes. It's everyone's different. I've seen a few cases where it's very subtle. They don't feel anything. They just have reduced vision. Right. But definitely many people are diagnosed with MS through optic neuritis. And unfortunately, you can only see in the back of the eye the optic neuritis if it's at the head of the nerve. Sometimes it could be retrobulbar behind the eye. So sometimes in order to validate if someone is suspicious for optic neuritis, you would do an MRI. if it's not visible. So sometimes the nerve looks perfectly healthy from the inside part, but then you have to look in behind the eye, and the only way to do that is to do an MRI. But with proper medication, many times the vision can return, and hopefully it won't reoccur. But that's definitely an emergency.
So, so all these are urgent care, emergent conditions, right? So these are something bad happened, let's treat it, right? I think something that people might be interested in, I think we've had a conversation actually outside of these four walls about, LASIX, right? For those glasses wearers out there, right? I wear glasses. I'll tell you, I've thought about it. The reason I haven't pulled the trigger is mine happened to be helpful in as much as whenever I'm doing a procedure to have the eye protection basically innately on my face, and I don't have to remind myself to put something on. It happens to add a protective layer that I don't have to think about. So I haven't gone through the process, but I know a whole bunch of people and other physicians who've taken the leap, and they come in with glasses one day, and the next day they come in, they look like a new human being.
That's right.
And it seems like it's relatively it's one of the most amazing things to in medicine. I always think about emergency medicine. So much what I do is palliative. Okay, it's not palliative in the sense that it's terminal and you can't fix. It's palliative in as much as for example, laceration repair. When I do a laceration repair, that pristine skin that was intact, no matter how good of a skilled plastic surgeon or emergency physician you are, and use the small sutures and everything is equidistant and it's beautiful, there's always some small degree of scarring that happens. You just can't make it as perfect as it once was. And then you see something like someone comes in and they can barely see, like myself right now, and then the next day they come in without glasses, and it seems like a miracle. It looks like one of those modern medicine miracles out there. So what's the lowdown on LASIX? Who should consider LASIX? Who's it the most beneficial for? What are, I guess, some of the risks of performing the procedure, and what have you found over following patients who have had it?
So LASIK usually applies to the front part of the eye, the cornea. The cornea, that red line, like I mentioned, has many different layers. It has the epithelial, it has the stromal layer, and it has the endothelial layer. The stromal layer is the thickest layer. So essentially, in LASIK, they thin out the stromal layer. So instead of you having to wear minus glasses, they decrease the curvature in a sense, or decrease the power of the cornea. So the light entering your eye will naturally focus properly. So instead of having you wear glasses. Now, that's important.
So just simple terms again. Someone has the egg eye,
right,
and has a very thick stromal middle corneal layer. They shave it down, and that way the light hits the appropriate back spot of the eye.
Exactly.
Okay.
Exactly.
And now, what if someone has the non-egg eye over there?
Unfortunately, there's no good quality LASIK for that, because to cut away is easy. But if someone has a very short eye, you don't need to cut away. You need to add.
Gotcha.
There are other things for them, but for LASIK specifically, it's really designed for nearsighted.
So for people who are nearsighted, they can see close, they can't see far, and this is...
Right, exactly. So of course they have to be a good candidate. So a lot of times their children, the teenagers, their numbers are going up, and the mom is asking, okay, when is my child, can we do LASIK? And we have to wait till their prescription is stable, because what if we do LASIK today and they're not done growing and their numbers are not stable, then the prescription of the LASIK procedure is not going to help as long. So you have to wait a few years, 1 or 2, 3 years, until you see a consistent, stable prescription. And of course, the cornea of the thickness has to be thick enough. And of course, the higher the number, the more you have to take away. And there's a certain category where if you take away too much, then that can cause issues. The cornea is too thin. So that's an issue as well. So they try to do the surface area of the pupils dilated, because if they only did it during the daytime, then that surface area is going to be different than when the pupils are larger. So it's important to make sure to get a proper area to do the LASIK. Otherwise, you'll get halos and double vision. Also, if someone has dry eyes, you have to treat the inflammatory dry eyes before you do the LASIK. So it's important, if you want to do the LASIK, to go to a highly rated physician and who has good ratings. And unfortunately, those places are not the cheapest, but it's your eyes and you want to have good outcomes. So overall, LASIK is super safe and it's very advanced technology, and many people are a good candidate. But there are certain things you need to know. So if you have stable vision and you're in your 20s, if you do LASIK and you're a good candidate, you're probably going to have good vision for 15, 20 years. But once you hit the 40s, naturally everyone will lose the ability to focus at near. So now that you have perfect vision at distance, down the road, you'll need reading glasses. So someone who's 38, 39, and they're an avid reader, and they want to have, and they're nearsighted, and they want to have LASIK, now they're going to maybe be more reliant on reading glasses. So if someone doesn't read as much, okay, not a big deal. So to set expectations of who gets it and what their quality of life is, what they do with their life is important.
Regarding the eye complaints and like more emergent complaints, and this is probably tachlis, so to speak, something that most people can relate to on some, I hope not a daily fashion, but it happens occasionally where you're dealing with a chemical, dealing with food and oil, whatever is splashes into the eye, right? So some chemical, thermal, some heat burn, so to speak, to the eye. So someone splashes on the eye. What should they immediately do? Who do they go for care? What's the sequela or the treatment plan for someone who kind of gets something into their eye? And I'm sure it matters based off of what they got in there, but if you give me a brief overview of it.
Yeah, absolutely. I actually had a case where a patient used a cleaned bottle that had a detergent solution, and they filled it up with contact lens solution.
What?
A cleaned bottle that used to have detergent solution.
Like Tide. Not that I'm supporting any specific brand.
Even stronger, like to clean the grit and grease off of the
stain
stove.
remover.
Yeah. So they really washed out the bottle, thinking, okay, now it's can be utilized for other things, and they put in solution, other type of saline solution, and then they stored the contact lens in that saline solution. And they basically essentially had a chemical peel of the cornea.
Sure. That's like an alkali burn, right? That's
exactly.
So there's an acid and an alkali.
Exactly. Yeah. So we have a pH indicator that tests what kind it is, because the treatment modality is slightly different. But the first part is just wash out the eye for 10, 15 minutes. Just keep washing out the eye. Ideally better saline solution or bottled water rather than sink water. But an emergency is emergency. Keep washing that eye out. And of course, we have to take a look to see if the pH is neutral. And if it's not, you have to continue washing that eye out. And once it's washed out, depending on the damage, we for sure give antibiotics, and we treat it as a glorified corneal abrasion. Mm-hmm. So we contact lens bandage, contact lens, and slowly but surely it can heal. I have a lot of cases where people get corneal foreign bodies, construction. They're not wearing their safety glasses, landscaping, pieces of metal going in. So we have to take out that foreign body, and then depending on how severe it is, we have to give a contact lens to cover up the and a steroid to calm the inflammation, and the contact lens to provide that comfort. So we see a lot of that, especially during sukkahs, the schach.
That's funny you mentioned sukkahs.
Yeah, usually I get all this foreign body. They didn't touch the schach for a year, and then they get stuff in their eye.
Right. You mentioned sukkahs for the rust or whatever in the eye, and use what's that thing called, the drill
an algae brush.
Algae brush. Algae.
Yeah,
algae brush, and it's like a fine drill almost. That kind of,
and it's pressure sensitive, so we don't want to penetrate the cornea.
It's always spooked me out, the concept of it.
Yeah,
but
it's
obviously
very scary.
In skilled hands like yours, it's not something to be concerned about. I noticed during sukkahs, the rate of splinters we get is out of control.
Oh yeah,
left and right. I mean, everyone's getting splinters. So if I can make one recommendation, we're not seasonal yet, but please wear gloves. Be careful. It can be a dangerous sport out there. But yeah, so it's the foreign body is definitely very important, and certainly to know what to do for the chemical burn. So, in an emergency, close the sink, bottled water, saline, whatever you have, please don't put saline in any under your kitchen cabinet fillers that you use for your daily appliances. That's not a good idea. I guess if we could reiterate like the dangerous conditions or the biggest signs and symptoms that someone should look for, when it comes to eye care, so sudden vision loss, flashes and floaters, an acutely painful red eye, chemical burns,
sudden double vision. Not only periodically when you read, that's important, but sudden double vision that could be a neurological issue as well.
And any sudden vision loss. So those are maybe your top 6,
Right.
Seek, ophthalmologic care immediately. Amazing. Dr. Klein, thank you for coming in. I appreciate you teaching us more about the eye condition. I thoroughly enjoyed learning more about how kind of your philosophy and your interest in the eyeball, which is I don't think it's unanimous. I think there's plenty of people out there that find it gross or icky, and to have one of the few clinicians, physicians interested in everything and all the particularities of the eye, it's kind of refreshing, and it's very invaluable to get your knowledge and to be able to share it with people. So I appreciate you taking the time to sit down with us.
Thank you. Thank you for having me.
All right. Thank you.